Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as treasurer of the World Federation of Neurosurgical Societies, the WFNS, in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANS. Important to tell you that with my team, we organized 54 webinars, including educational WFNS Symposium. This is webinar number 55. I'm glad and honored that this webinar is organized with the Neuro Oncology Division, Department of Neurosurgery at the University of Miami. In this occasion, I'd like to thank Professor Ricardo Comutar for such opportunity to have such wonderful collaboration. Let me, first of all, welcome all our keynote speakers, Professor Ricardo Comutar, Professor Michael Evan, Dr. Ashish Shah, Dr. Nitesh Patel, Dr. Dominique Higgins, and Dr. Alexis Morel. We have an outstanding program today, which is divided into two sessions. And as you can see from the flyer over the screen, all the topics are very interesting. Participation. Until yesterday, we had 375 participants over Zoom. We are also doing live stream over the Facebook page of CANS. The address is seen over the screen, over YouTube channel of the Egyptian Society, and over the Neurosurgical TV. In this occasion, I would like to thank John Bennett. Actually, he's doing a great job in promoting our series of webinars. All attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. This is the type of certificates we are offering. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies. Concerning certificates, in all previous webinars, participants were printing their certificates electronically. However, some of them encountered some technical problems. That's why my IT team, they are now using a new method. Certificates will be sent to you automatically within a week after the webinar is finished. Thanks to IT team for the professional job they are doing. Certificates will be sent only to participants who participated for the time specified by the organizing committee. Please, that's very important, because the organizing committee realized that some participants just participate for 5 minutes and they're asking for certificates. And so according to the webinar, if we have 3 sessions, 3 different subspecialties, at least it will be 1 hour. But for this webinar, in order to have the certificates, which is approved by the World Federation, you have to attend the webinar completely from the beginning to the end. Another important point, that names will be written according to the name in the account email. If you registered from another email, the certificate will have another name. Please register from your own email. For webinar 53, we had 365 participants. We sent certificates to 122. For webinar 54, we had 524 participants, and certificates were only sent to 169 who participated for at least 1 session. Important to announce that webinar 56 it's going to take place next Friday, 17th December, at our usual time from 2 to 5 p.m. Egypt time, 12 to 3 p.m. GMT. Today we started 1 hour late because the time in New York and in Miami, in Florida, is very early. If we start at 2 p.m., it's going to be very early, 7 a.m. That's why we start later 1 hour. Our next webinar will be collaboration with the Spine Committee of the World Federation of Neurosurgical Societies and the chairman, Professor Salman Sharif. It's going to be about management of spine trauma. Important to announce that the Pan-Arab Journal of Neurosurgery was relaunched after a silent period of 10 years. I'm honored to be the editor-in-chief of this journal, and submission and publication is free. It's an open access journal through the address seen over the screen. As treasurer of the World Federation of Neurosurgical Societies, also I'm glad to announce and to advertise for the Bogota 2022 Colombia Congress, which is the World Congress of Neurosurgery organized by the World Federation of Neurosurgical Societies. I encourage everyone to participate in this important event, which takes care in Bogota from 13 to 18 March 2022. Important also to have this announcement about the Third Man's Congress, which takes place in Cairo, Egypt, 27 to 30 October 2022. I'm honored to be the president of this Congress, and I'm honored to work with my friend Alberto De Litala, who is president of the Mediterranean Association of Neurological Surgeons. All of you are invited, and I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much for attention. Now I will give the speech to Professor Ricardo to say his welcome note.
All right, wonderful. Thank you so much, Nasser. It's a real honor to have me and the rest of the group here. Super proud to showcase what our group has done as a team. I do have to say, very amazing that you guys have put on 55 world-class seminars. That is truly kudos to you and your entire team. There's not many good things that have come out of COVID, but I think that the educational component in terms of these global symposiums, obviously Mike Ivan, who founded the Global Brain Tumor Symposium, can talk more about it. But this is one of the few good things that have come out of COVID in terms of being able to collaborate with people like yourself and your group across the world so easily. This is something that never really existed before, but obviously this is great for all parties involved. I'm going to start by just introducing our team. I can tell you that I am beyond proud of the people who I work with and the multidisciplinary care that we offer. I'm going to start just by talking about how we built this program over the last decade or so. And then we're going to have Dr. Michael Ivan, who directs our research program here. He does all brain tumors, but he does focus upon skull base. World-class skull base surgeon. He's going to be speaking about NF2 and schwannomas and how to preserve hearing. Then we have Dr. Ashish Shah, who's going to be joining our faculty coming up this July, currently at the NIH. And he's going to be talking about our paradigm for supramaximal resection of gliomas and how that improves overall survival. Then we're going to have both of our fellows that are just truly phenomenal speak about their research. Nitesh Patel, who's going to be heading up to New Jersey to head up the brain tumor program there, talking about enhanced recovery, basically how to do brain surgery and get these people home as soon as possible, which has been shown to improve recovery, improve quality of life, and how we expedited discharges for these patients. Dominique Higgins, who comes from Columbia University, talking about dietary regulations of ferroptosis in glioblastoma. And then Alexis Morel, who is our dedicated neuro-oncology research coordinator, fully trained neurosurgeon down from Argentina, talking about traditional and non-traditional eloquent region tumors. It's a very hot topic because, we typically consider language and motor as the only eloquent regions of the brain. But now that imaging has become, more enhanced, we are starting to understand that there's parts of the brain which were once considered non-eloquent, which are now eloquent. And so it's a real paradigm shift. He's going to talk about how we are leading that paradigm shift towards understanding what is truly non-eloquent and what is eloquent. So anyway, I'm going to get started, if that's okay, sharing my screen here. All right, let me know when you can see this. Can you guys see that?
Yes, perfect.
Perfect. So, so the first talk here is not going to be scientific. It's not going to be based on any, amazing surgical techniques or any hardcore research. This is going to be about how you build a brain tumor program and how you build a brain tumor center. This is just as important as any basic science talk, any technical talk, because this is these are the topics that are never taught during training, certainly not here in the United States. I don't think they're taught anywhere else either. But basically over the course of 7 years of training, residents learn how to do neurosurgery, but they don't learn how to get the patients, how to build their own practice, how to build their center. So these are really applicable techniques for all of neurosurgery, not just brain tumors, but spine, vascular, pediatrics, same techniques really do apply. So we'll start with, this is going to be the most important slide of the talk. If you remember nothing but one slide, this is by far the most important, and that's volume is power. I can't really emphasize that enough. Volume is power, and it gives you the ability to build a true center of excellence. And by what is power, I mean expertise. So just like playing a sport, if you play golf once a month, you're going to be terrible. If you play it every single day, you're going to be great. And so surgery is no different. If you're doing these complex surgeries early and often, then you're more comfortable with them, you have better outcomes, and you really become an expert in these types of surgeries. Volume is going to be training. So if you're going to train the next generation of leaders in the field, your residents and fellows need to see these cases often, and they got to see them when they're early in their training. So PGY 1, 2s, 3s, that's how you create the next generation of leaders in the field. Volume is going to be data, it's going to be research, and it's going to be clinical trials. You certainly can't do any database research if you don't have good volume. So again, volume is going to push the envelope. It's going to allow you to do research, not only clinical trials, but also basic science. Volume is going to be reputation, locally, nationally, globally. The more surgeries you do and the better outcomes you have, that's better reputation for you and your program and your entire institution. And finally, most importantly, volume is going to be institutional and programmatic support. So everyone who finishes training goes somewhere and they're going to be asked to build something. It could be, again, brain tumors or spine or vascular. And everyone has asks. They need extra OR time, they need a nurse practitioner, they need extra office space or what have you. And at the end of the day, the institution has a lot of requests and they're not going to listen to everyone. But if you're bringing in volume and you're generating the cases, the institution is going to listen to you. So if you're doing one brain tumor a week, no one's really going to care about what you're requesting. If you're doing 5 or 10 or 20 brain tumors a week, now you have the ear of administration because you're generating revenue. And the person who generates revenue, or the program which really generates revenue, that is where they're going to put most of their support. So again, I would really say that instead of asking and then producing, you really want to produce, show that you are value added, and then ask. And so again, volume is going to leverage it such that you can continue building your comprehensive program. So how do you build volume? Obviously, it's very complex, tough to cover in just 20 minutes. But I would say that the bottom line is that building volume really requires work, and that's not the operating room. If you just show up to work and you operate and you go home, you're really missing most of what it means to build a practice. Surgery, I always tell our residents, is the easy part. No one's bothering you. You're doing what you love. That is the easy part of our job. The hard part is everything that goes on outside the operating room when you're trying to build a practice. And what I tell, again, our trainees is the easiest way to do it is think to yourself, there's many options out there. There's many talented surgeons. You're not God's gift to neurosurgery. Why should patients come to you? And the moment you start asking yourself that question, then the entire paradigm becomes much more easy to understand. So the 3 A's, I'm pretty sure everyone's heard about this, but if not, these drive practice referrals and these drive program building, period, end of story, plain and simple. Number one, you got to be available. You got to answer your cell phone. It's not fax, it's not office, it is text, it's email, and it's cell phone. And if you do nothing else but you answer your cell phone, you will build a practice. Number two, you have to be affable, and that just makes sense, right? People have to want to work with you. If people call you and you're not pleasant or you're abrasive, it doesn't matter how good you are. People are not going to want to work with you if you're abrasive. So you have to be affable, and it doesn't mean you have to be fake, but just have common decency when you're dealing with people. And then finally, actually least important, amazingly, is how good you are. So we all know bad surgeons who have busy practices, and that's because they have the first 2 A's. Ideally, you have all 3 A's, and that's when you can really dominate. So there's a lot of key steps in terms of building a program. Again, I really want people to understand this is not about brain tumors. The same principles apply to any program in medicine, really. And we'll go over all of these, and we'll focus on how we built this Brain Tumor Institute, which started about 10 years ago, and we had a lot of challenges back in 2012. Had to start a fellowship, train the future leaders, bring in cutting edge surgical techniques, start a brain tumor bank and database, clinical trials, translational research. But again, nothing can happen unless you build up case volume. So case volume was our number 1, 2, and 3 priority. So targeted faculty recruitment, your first hire needs to be a clinical workhorse. If you're going to start a program, your first hire cannot be a researcher, cannot be a 50-50 person. All that's important, and you need that eventually. But your first hire has to be a surgeon that's 100% focused on just expanding that overall clinical practice. Once you have the volume, as I said, everything else falls into place. Number 2, so you got to raise awareness of your program. So here, no one really knew about our institute. And so we went on a mission to inform South Florida about what we were offering. Googled South Florida hospitals. There were 92 hospitals in the area. Some were small, some were big. Contacted each and every one of these 92 hospitals, asked to speak at their grand rounds, tumor board, CME event. We were allowed to speak at 77 of them. So we gave 77 talks over just a year and a half. I'm not going to belabor this, but this is what you need to offer if you're going to be a cutting edge brain tumor program. Awake craniotomies, advanced neuronavigation, laser ablation, brain path Vicor, fluorescence guided tumor resection, robotic guided stereotaxy, skull-based endoscopy, and vaccine-based clinical trials. So these are what draw the patients into your brain tumor program. The overwhelming majority of patients that come into a brain tumor program don't come through radiation. They don't come through medical oncology. They come through neurosurgery. And so you need these surgical innovations. Even if these are not applicable to patients, they still come for that. So for example, for every 10 patients that come to me asking for laser ablation, 1 out of 10 get it, and the other 9 get a conventional craniotomy. But the laser ablation is what got them here because it's cutting edge. So again, you really got to have surgical innovations because this is the pathway towards getting the vast majority of patients into your program. Community outreach. So it's important to get involved with these local support groups. Florida Brain Tumor Association, Voices Against Brain Cancer, PAPCOR, and the Women's Cancer Association. So we immediately partnered up with all of these groups, spoke at their events. We are part of their board of directors. And so, yes, doctors do the referrals, but patients will often get referred through these support groups. So I really say that you should increase your overall footprint by being involved in these support groups. So this is a whole nother avenue. You can't just focus on the doctors. You want to focus upon the overall community because a lot of patients will reach out to other patients who have had neurosurgery, and that reputation carries a lot of weight. Expanded catchment areas. So when you're trying to figure out where you're going to get the patients from, you have to identify gap zones. You don't want to spend all your time trying to recruit patients in an area where you're already getting the vast majority of referrals. So for us, we didn't want to focus on Miami-Dade because most of those brain tumors were already coming here to the university. So Broward and Palm Beach, there was a big gap where these patients were only an hour from us, hour and a half, 2 hours at most, but they were leaving the state. They were going to other medical centers. So there was a big growth opportunity there. So we spent a lot of our time marketing and really educating those doctors in that area. And that was a huge boon for us. So again, learning point here is if you're going to spend time trying to educate local doctors, you want to spend it in places where you're not already getting the vast majority of referrals and what has the biggest overall potential for growth. How do you make these referrals facilitated? So it's not enough that the doctors and the patients know about you. You got to be available. As I said, if you do nothing else and you answer your phone, you're going to be busy. This really depends on who you talk to. There's the older generation that doesn't like always being around their phone. They want to use fax. They want to use their office number. In the year 2022, which is what it is basically, office phone and fax is completely irrelevant. It's cell calls, it's text, and it's email. And if you don't like this and you don't get on board, unfortunately, you will not be successful. So I always say, either get on the train or get run over, because the most able doctor doesn't always get the referrals, but the most available doctor almost always does. Hopefully those two go together. And unfortunately, you got to be by your phone and you got to be responsive. But it's not enough that you're available. You have to make these referrals seamless. So for example, if a doctor calls me directly and he's like, hey, Rick, I need you to see John Smith, who has a pituitary macroadenoma. If I tell them, have them call my office, that's wrong, because that doctor could have gotten my number over the internet. Now they still have to call some random central, scheduling agent who's going to schedule this patient out 6 weeks from now, 8 weeks from now, who knows? And you're probably going to lose that referral. So when someone calls you, the answer needs to be sure, give me the name and number of the patient, and my office will then expedite. You now control that referral. The doctor feels better because he's made that referral, and then you can then expedite it. So then how do you actually expedite? So it's not enough that you've gotten the information. Your office needs to realize that brain tumor patients do not wait. So it can be a 1 centimeter convexity meningioma. To them, it's the end of the world. It's a life and death, diagnosis. If you put them out weeks from now, which is what most places do, they're going to go someplace else. So I always say, and our group always says, all patients are seen within 48 hours. Once they're seen, if it's an elective surgery, you can book them down the road weeks or months in advance, but they need to be seen right away. Brain tumor patients do not wait. That's where it's different than spine. Spine patients may have had pain for months or years, and they're going to wait. Brain tumor patients need to be seen. So we see patients 5 days a week, often like in between surgeries, triple, quadruple book, because you need to get the patients into the office. And as I always say, access is everything. If you increase access and you allow patients to have access to your care, your program will explode. So fostering collaboration with the community. It's important to understand that the vast majority of patients do not come from the university. They come from the local community. And you need to integrate the academic center into the community. So if we were to say as a group that we're only going to treat patients at the University of Miami and no one else, that would limit us to about 10% of all the brain tumors in the area. So you really need to integrate with the academic community. And at the end of the day, think to yourself, why would a private practitioner not want their brain tumor treated at the university here? We have the best doctors, we have the best outcomes, we have the best technology, all the clinical trials, all this team that we have here. But really, if you think about it, there's a lot of roadblocks. Most doctors have no idea who to call, so they're not available. Number two is access. If they get through to that person, they're probably going to be scheduled weeks or months in advance. And there's no communication. So most doctors, when they see a patient, they'll fax a letter or they won't do anything. And so there's no communication. And finally, most doctors at the university will see a patient from the community. They will operate on them and they will keep them in the academic center. They will not send them back to the community. And that's practice building 101. Never steal a patient. If someone sends you a patient, take care of the patient and send it back to that referring doctor. So that's how we've solved all these problems. Always available. All of our cell phones are available. Doctors in the community know how to reach us. Easy access. Patients are all seen within 48 hours. Constant feedback. We have the cell phones, the emails. Very simple. Saw your patient, does need surgery, doesn't need surgery. Here's the deal. And the patient always goes back to the referring physician. As I said, that is practice building 101. So if you can incorporate academia with the community, that's where you truly have an exponential growth in case volume. Networking, this is key. So you want to store your contacts somewhere where they're not lost. Currently, we're about 8,000 to 9,000 referring physicians. This allows us to constantly update doctors, let them know what's going on pre-op, post-op, follow-up. MRI collages, fellows love doing this. You can just ask Nitesh and Dom. This is the highlight of their day. They put these MRIs together, makes them feel like they're part of the team. As I said, fax is pointless, and you really want to open up lines of communication, form these networks. So this is a very simple text that you'll see on post-op day 1. Joe Smith doing well, no issues, neuro intact. Home today, MRI confirms gross total resection of his large bifrontal meningioma. That took me about 10 seconds to dictate. This took the fellow about 1 to 2 minutes to put together. You send this to a doctor, they will never send another brain tumor to another doctor. They feel involved. They know exactly what happened with the patient. They know the type of surgery, and it's better for the patient. It's better for the doctor, and it's better for you. So a very simple gesture like this goes a long way in terms of overall patient care. This just shows how the networking can work at a very high level. Once people get to know your program, you will get direct referrals from radiologists. This is a radiologist who was about 5 hours away from us. In the MRI report, 1, large right-sided mass, 2, go see Rick Komatar. So you're never going to lose this patient. It's on the MRI report. It doesn't depend on the referring physician, on the oncologist, on the neurosurgeon. This patient's going to come to see you. So what did we do? We called this radiology center. We spoke to this doctor. We followed up with him. We met with all the doctors at this radiology center, which is the largest MRI center in Florida. And now any brain tumor that comes out of this MRI center immediately says, go to the University of Miami. So this is just an example of how that networking works. And you can get these patients at ground zero as opposed to word of mouth or down the road. So this is the way that we do our patient referrals. There's a lot of ways to do it, but this is just the way we do it. Most of the referrals come directly, call, text, or email. We get the name and the info of the patient, send that info over to our office schedulers. Our office knows every new patient seen within 48 hours. See the patient, make a plan, talk to the doc, correspond after the surgery, correspond after discharge with the images, and then correspond after follow-up. Now, this is a lot of work. I'm not going to downplay that. It's definitely a lot of work, but if you're organized and you have discipline, this is definitely doable during a normal workday. Social media, internet presence. So this is another point of contention between the older generation and the younger generation. Older generation doesn't like marketing, doesn't really get into the internet, doesn't get into social media. Unfortunately, this is the world we live in. So as I say, you either get off the tracks or you get run over. Just think to yourself, any patient that gets referred to a doctor, let's say a patient gets referred to Mike Ivan. What's that patient going to do? The first thing they're going to do is they're going to Google Mike Ivan. So they don't know Mike Ivan. They don't know anything about him, but whatever's on the internet has to accurately reflect Mike Ivan and the world-class surgeon that he is. So Health Grades, Press Ganey, Instagram, Facebook, Twitter, university webpage. You need to make sure that if you're doing cutting edge research, that's on the web. If you have a cutting edge technique, that's on the web. If you're promoted, that's on the web. So really shopping for a doctor is a lot like shopping for a wine, right? I know nothing about wine, but if I go to buy wine, I'm buying the coolest bottle. It might be good wine, it might be terrible wine. I have no idea, but I'm buying the coolest looking bottle because just because I don't know wine. And most patients, I would say 99% of patients don't know neurosurgery. So when they get referred or they're looking for a neurosurgeon, they don't know that Mike Ivan is world class. They're going off what is on the internet. So if someone is a phenomenal surgeon and it just says Joe Smith, neurosurgeon on the internet, you're going to lose patients. So it's not about lying. It's not about exaggerating. It's about making sure that your online presence and social media presence accurately reflects the type of surgeon you are, because this really does drive overall patient referrals. Finally, superior clinical outcomes. So everything I said is important, but at the end of the day, patients are your biggest referral source. You will hit a point in your career where you've done enough surgeries where your patients alone will generate referrals, but they have to be happy and they have to speak well about you. And so again, focus on your patients, keep patients as your first priority. So in academic neurosurgery, there's a lot of other distractions. There's mentorship, there's education, there's research, there's organized neurosurgery. All that stuff is important, and we all do it here at the university. But your number one priority as a neurosurgeon, should be clinical outcomes. And so keep your complications to a minimum. Don't get distracted by administration or teaching or research. All of that is important, but you got to keep patients as your priority and your complications to a minimum. So your reputation as a neurosurgeon is formed in the first 3 years of practice. Unfortunately, that's the way it is. So if you come out of a good program and you make a couple stupid mistakes early on, you are labeled as a hack, and it's very hard to get rid of that reputation. You could also come out, be very safe, have very few complications, people view you as a safe neurosurgeon, and then you have carte blanche. So again, everyone has complications. No one's trying to say they have no complications, but you got to avoid the avoidable complications. And we all know what that is. And you do that by really keeping patients as your first, second, and third priority. Keep outcomes favorable. Again, that's your cachet as a neurosurgeon. What are your outcomes? Research, RO1s, leadership, all that's great, but nothing trumps outcomes. Outcomes, that is the way you're measured as a neurosurgeon. Keep your outcomes favorable, and the rest will fall into place. Round twice a day. Fellows will tell you about this. And then, as I said, happy patients means more patients. At the end of the day, you could do a great surgery, but if you never see your patient and you never correspond with them and you're not available, they're not going to be happy. But if you interact with your patients, and that can be over email or phone calls, patients will have that connection and they will speak very highly about you. So wrapping up, you can see how the brain tumor volume here just exploded over the last 9 to 10 years. 2011, it was about 200 brain tumors a year. Now we're up to about 1,300, making us most likely the busiest brain tumor program in the entire country. Looking at the overall percentage of cranial surgery in Florida, 2011, we were doing less than 0.5% of all the cranial surgeries in Florida. 2018, which by now it's much more, 1,000% increase in just 7 years, doing nearly 5% of all cranial surgeries in Florida. When you think about that, it's really a mind-boggling number. It's the third most populous state in the United States, and for every single cranial surgery, including shunts, in the entire state, 1 out of 20 is done here at this hospital. Distance traveled, you can see here, was 5 miles. Now it's 45 miles in terms of average distance traveled. That shows how we've marketed, how we've really reached out, not just locally, but throughout the entire country. This just shows that growth, 25% of the growth outside of South Florida, all along I-95 out to the west coast of Florida. This was, again, over 1,200 brain tumor surgeries per year. Now it's about 1,300, by far the busiest program in the state, most likely the busiest program in the country. 35% of all brain tumor surgeries in Dade County, 20% of all brain tumor surgeries in Broward, and 20% of all brain tumor surgeries in Palm Beach. This is the market share. You can see here how it's exploded, 15% up to 51. And then this is going to be this is the last point, talking about how, as I said before, volume translates into program. And so you can see here, how did that affect us? 2011, we were doing only 200 brain tumors a year, currently over 1,200. What was the downstream effect of that volume? You can see here how we brought on cutting edge techniques. We really had terrible neuropathology. Now we have world-class neuropathology simply because of the volume. We had 1 medical neuro-oncologist. We now have 4, and we're going to be adding 2 more in the next year. We had no tumor bank, no database, now one of the biggest in the country. We only had 1 clinical trial back in 2011. We now have 15, which is on par with any brain tumor program across the country. We had 0 brain tumor researchers. We now have 4. It'll be 5 starting in July. These are dedicated brain tumor researchers with funding. We had 2 brain tumor publications back in 2011. This past year, we had nearly 50, showing how the residents and the fellows got involved. We had no fellowship back then. We now have one of the best brain tumor fellowships in the world, one of the few CAST-approved fellowships. And again, there was this growth opportunity, and it shows how, as a team, we've really capitalized on that and formed a comprehensive center of excellence. All of this is summarized in this book, which I put together with Dan Eichberg and Bob Spetzler. This goes over the business of brain tumors, summarizes everything in this talk with more detail. Basically, all the stuff that goes into building a practice, building a program that is not the operating room. And I think this is absolutely critical, especially for residents, fellows, and any junior attending. So again, thank you for your time. Welcome any questions. And again, thanks for having our comprehensive team on here, Nasser.
Thank you very much, Ricardo, for this great talk. Actually, it's a very excellent presentation. And it's very important to know that a great neurosurgeon is not a neurosurgeon who has excellent skills only, but he should be great in everything, in principles, in ethics. He should have a good reputation. Thank you very much. I'm actually amazed by the amount of scientific work. Everybody knows Professor Ricardo, the amount of publications done by this team in Miami University is amazing. I think all the world in neurosurgery understand how powerful the research work and programs in Miami University, the Neuro-Oncology unit, as under the leadership of Professor Ricardo. Thank you very much. Can you introduce our next speaker?
Yes, absolutely. So the next speaker is going to be one of my colleagues and best friends, Dr. Michael Ivan. As I said, world-class surgeon, focuses on skull base, but honestly can take out any brain tumor. Mike Ivan trained at UCSF. He then spent a year with us here doing a fellowship. We recognized immediately what a talented person he was, and so we kept him on faculty. He's been promoted early. He has a tremendous biography in terms of publications, funding. He runs our brain tumor program research here, and he'll be speaking today about some of his skull-based work that he's doing, looking at NF2 and schwannomas and how to manage them in terms of hearing preservation and restoration strategies. So it's really a pleasure to introduce Mike.
Thanks so much. Really such an honor to be invited to talk to the FNS, the World Federation of Neurosurgical Societies, and CANS, and everybody else who's associated with this conference today. Really amazing to be able to reach out to the world, and I just want to congratulate all of you that have put these symposiums together for the last, over a year, 2 years now. It's really just a tremendous amount of knowledge that we can now share across the world, and it's so important for everybody to be up to date on what everybody else is doing, and it's with the effort of all of you to do this. So thank you for including us in this educational experience. Also, very honored to be among some of my colleagues here today. All the work we work together on, and really proud of all the presentations that are coming out of our university today. And so I think you'll be excited to work with, to see what everybody has to say. And special thanks to Dr. Komatar for being such a great leader of our brain tumor program. So thanks, Rick, for the introduction. My name is Mike Ivan. I'm one of the brain tumor skull base attendings here at University of Miami, and this will be what I'm talking about. Here's my disclosures. But I think in this audience, I don't tell much time kind of giving the introduction to what vestibular schwannomas and NF2 are. We know that they are benign cranial tumors involving Schwann cells in the cochlear vestibular nerve. We know they present with hearing loss, dizziness, facial paralysis, and other complications of brainstem compression. And they're very prevalent. More than 1 in 2,000 patients end up having a vestibular schwannoma sometime in their life. So dealing with the sporadic type are very common with the treatment options. If we find them, the patient's asymptomatic, we observe. If they grow, then that's when we intervene, and it's a very complex kind of paradigm to decide between radiosurgery and microsurgery, that we balance this ability to kind of preserve somebody's hearing as long as possible, but yet also to kind of control the tumor growth before it causes any other issues. And I think every physician kind of does that balance a little bit differently, although there's been many kind of updated guidelines to kind of go through that. Part of my talk is going to be really discussing hearing restoration. So I think it's important to understand, the hearing issue in these tumors. There's been a lot of discussion about even the best surgeons in the world about what is the role for surgery, for hearing preservation surgery, and the numbers are all over the place. And there's lots of different characteristics that kind of go into deciding what is the hearing outcomes in these patients. Size of tumor is very, very obvious. Fundal impaction, lack of fundal cap, inner ear invasion, IEC erosion. And I would say that these numbers here of 48% hearing preservation with less than 2 centimeters are a little bit exaggerated, and that it's difficult to consistently get that number because there's many factors, as we'll talk about next, that go into hearing loss, not just surgical technique. And so if we look at what are the reasons for patients to present with hearing loss in the first place, I think it's important to kind of know that this is also not a very straightforward answer. In 2012, the idea of that not only is this compression of the tumor to the cochlear nerve, it's also dysfunction of the cochlea itself that can contribute to hearing loss in many different ways, is a key factor to this kinds of problems. And then it wasn't really until just a few years ago in 2015 that Wally noted that there's actually secretory factors of the tumor that can cause hearing loss. And this is why we see hearing loss in patients that have acoustic neuromas that don't even grow in the first place. And so you could watch somebody with this, they have these saltatory growths. You watch them if they're not growing, and yet you find the audiogram is worsening. And why is that? Well, it ends up, it could be because they're secreting TNF alpha, and that's an ototoxic molecule that could cause destruction. And so it's important to understand all of these mechanisms in hearing loss, because as a surgeon, deciding when to intervene and how to intervene for either sporadic or NF2 is so critical. And when we talk about, just to highlight how we deal with hearing loss here at the University of Miami, if somebody comes in with worsening hearing loss that's ongoing, we always start first with corticosteroids to get their hearing to the best status before we intervene, whether it be with surgery or radiation. Other ways, especially with NF2 patients, are with Avastin, because you could actually stop the growth or shrink the growth. In some of these patients, it's been demonstrated, and that could help prolong hearing for as long as you can, although it doesn't end up preventing hearing loss for the longest time. We don't typically use this for unilateral vestibular stenomas, but we do for NF2 patients. And that brings us to really the complicated situation of dealing with NF2 patients, which we now have a robust program here at the University of Miami for helping these kinds of patients. As you know, it's also a dominant disorder. It ends up leading towards bilateral vestibular stenomas, which ends up leading in deafness because you have growth at some point in their life on both cochlear nerves. Tumors tend to be more aggressive, and then they have other associated factors, meningiomas and other tumors that I'm not going to go into today. But the decision making for the vestibular stenomas becomes much more of a delicate matter, in that we want to preserve their hearing for as long as possible, because they're going to end up going deaf at some point. And so the focus on hearing preservation is much more apparent here, talking about observation, offline and chemotherapy or new kinds of chemotherapy to control these tumors, and then radiosurgery, and then last but not least is microsurgery as the least part, because we know that they're going to go deaf at some point. So NF2 obviously is related to the NF2 gene mutation, which affects the myelin protein. 50% is familial and 50% is spontaneous. And here's their average life expectancy. Again, I'm not going to go into the whole syndrome, as I think we're all very well of what that it consists of. As far as the treatment, our paradigm here is we try to use chemotherapy like Avastin. We actually have a new clinical trial that we just start now with brigatinib, which is an EGFR inhibitor for these kinds of tumors, to try as well. All of these things are trying to control the tumor growth before you intervene. Then radiation, and then obviously if the tumor persists, which many times it does, is surgery. And you need a comprehensive team to deal with this. So here's just one case presentation. This is a little bit of an unusual case because it's an older person who presents with NF2. Normally they present very young. A 64-year-old female who had hearing loss. She actually presented about 20 or 30 years ago with a left-sided vestibular strenoma with a subtotal resection outside institution, and then followed by gamma knife. And that actually did really well as far as controlling the tumor. She did have complete hearing loss on that left side. And what they didn't notice was on one of the serial MRIs, in fact, in 2010, there was a small vestibular strenoma on the contralateral side. And so on serial imaging, that was followed at an outside hospital, and it showed significant growth here, almost 1 centimeter or 2 centimeters in 5 years. So it was radiated. She still had good hearing at this point in time. And then after that, we could see that there's some necrosis of the tumor. Hopefully this was showing that the tumor is responding to radiation. And then after that, the tumor continued to grow, unfortunately. So at this point in time, we met her in 2018. The tumor was actively growing. She had slowly declining hearing, and then became, what is the treatment at this point in time? She already has no hearing on the other side. So we encouraged her to try Avastin. Unfortunately, it was not able to be accessed by her. And so we ended up following her with audiograms, and it was quite quickly that you could see her hearing here in the right ear basically went down to non-serviceable hearing in 2019. And then and this was the final ABR audiogram before surgery. And so what we did here is our first auditory brainstem implant. We didn't think we were going to be able to preserve the cochlear nerve during surgery because of the fact that this tumor had been radiated, and it was now is almost 3.5 centimeters by the time we operated on it. And so what is left for hearing restoration is to actually place an implant on the cochlear nucleus that basically receives auditory response signals from the outside surrounding and then transmit it to the brainstem so that the patient could get some response. This is not a new technology. It's been around for quite some time. In fact, in the US, it was initially approved in 2000. The current device was approved in 2015. And we talked about here, you don't need a cochlear or cochlear nerve intact to use it because it goes right on the brainstem itself. This is what the entire internal device looks like. 21 electrode array. It's very small, about 0.7 millimeters each electrode. And basically it delivers sensation to repair and give you some kind of hearing sensation. And it varies based on the patient and how many electrodes are actually working. This is the internal, this is the external device that's used. So it's basically it's like a hearing aid on top of the ear and then a magnetic setting that basically goes over the receiver device. So this device is completely internal. There's nothing coming through the skin, and this is all kind of remote and lays on the head. This is the size of my hand, and this is kind of us placing it here along the brainstem itself. What we use it for is primarily patients that are either deaf or going deaf because of tumor growth, and the cochlear nerve cannot be preserved for a cochlear implant, and therefore this is really the only option for you. Obviously requires, again, an entire team of specialists, neurosurgeon, ENT, and a great audiology team with neuromonitoring and everybody else that you can see pictured here. When you place these devices, it's critical to understand all the cranial nerves, because as you place the paddle on the brainstem and stimulate, you will need to understand, if you stimulate any of these nuclei, what is it going to do to the patient, and be ready for that. So if you're stimulating the vagus nerve, you have to be ready for not only issues with swallowing, but also with high blood pressure and tachycardia. And that's why it's critical to have monitoring available throughout the placement and also when you turn on this device in the future. This is how we plan our surgeries here. This is an incision that we use. We typically do translab to approach these kinds of tumors, because again, we're not trying to preserve the cochlea and or the labyrinthian area. And this is where the receiver is going to go underneath the skin. Here's the translab, here's a tumor resection, and here's us securing the receiver on the bone underneath the skin. After that, we then place the paddle electrode, and you can kind of customize it so it lays flat into the lateral recess of the fourth ventricle, which is where kind of you find these landmarks of exactly where the ventral cochlear nucleus is going to be located, which is important to be right on it. But as you place it, then in the operating room, you have your audiology team to then do stimulations, and you can actually get feedback at the time of surgery to understand how the placement's going. And what we do is we actually end up testing all the combinations of the electrodes to find out how many combinations are on the nucleus, which will then basically correlate to how well this device will work in the long term for this patient. And you can see here that if it's too deep, superior to inferior, you're going to get a different feedback. You're going to get different combinations that are going to work or not, and you're going to get different side effects responding to which nuclear you're actually stimulating. And so it's important to kind of adjust this multiple times to get it in the most optimal place. After this, we typically use fat for packing our translabs and secure the catheter with stitches. This is what the post-op CT will look like, and you can see how it's really tucked in quite deep into basically the foramen Volushka here, resting on the brainstem itself. After surgery, these patients come back in 6 to 8 weeks. We like it to scar in for that period of time before we do the final programming. And then it's a full 2 days of actually programming a device with the patient, which is actually quite exhausting. We typically have a critical care attending and cardiac monitoring for this, because again, if you're stimulating over the vagus nerve, a vagal nucleus, it could be an issue. This is just an example of the team that's there during our first patient stimulation. And it's quite an experience for the patient. I'll just play. This is the first time that now she's heard any sound in 8 months. So she, we have a large Spanish population, so she's speaking Spanish there. She's just basically saying how amazing this is that she's now able to see a sound for the first time. And immediately she's able to improve her lip reading ability from almost like 60% to about 95%. And then without lip reading, she was automatically within the first day able to kind of understand word greater than 50% with no lip reading. That's not a typical result, but it was exceptional for this first patient. And in the last 3 years, we've done an additional 8 patients here of ABI implants at Miami. What do these patients typically get out of this? I mean, most of them are able to detect environmental sounds and detection of speech. Most could understand perception of rhythm and volume of speech and some speech recognition, and then exceptionally small number of people will actually be able to have complete speech recognition without lip reading, which is really amazing. The data shows that if the better placement you have and the number of combinations of the stimulates you have, the better outcome these patients are. And what is also interesting is, unlike a cochlear implant, that the long-term durability of an ABI is actually quite good. And this is 30-year data here showing that the initial ability for word recognition and speech recognition is persistent for that long time. There's no degradation of the noise over time. People are also very satisfied with using it. So that's just part of our program. I mean, the other part of our research program is really trying to prevent this from happening in the first place, right? I mean, in a perfect world, we'd be able to treat these patients well early on in their lives. They typically are made with diagnosis of NF2 early on. And then after that, the goal is to try to prevent that. And so we've kind of built a very robust program. Tackle this. You would think that NF2 is a very simple kind of tumor. It only involves one gene in one pathway, but that's not true. The Merlin pathway is actually very complicated, involves many different pathways here, as you can see. And many of these have been tried in clinical trials and have failed, unfortunately. In fact, the one that we're trying right now, brigatinib, looks promising, but again, it's just a single target. And this is the universities are involved in this clinical trial now to target the RTK pathway. So what we've done here is trying to develop a multimodal therapy involving research people as well as the clinical people. We've collected all of our tumors. We do genome, epigenome, and transcriptome analysis. We then implant them in mice, and we use targeted therapies. This is done primarily by my ENT partner, Dr. Christine Din, and we work together in collaboration with all these projects, but she's just a phenomenal partner. And we focused our research basically on these 5 areas: observation, radiation, chemotherapy, gene therapy, and surgery. And just to quickly go through them, we basically developed an animal model where we're able to take these patients' samples and develop a cell line and actually implant them right at the cochlear nerve in the CP angle of mice. And what that's able to do is not only create tumor growth, but actually create a model where we could have hearing loss and balance changes as the tumor grows. Now we have the tumor growing in the right place, and we have both the clinical outcomes of tumor growth and the symptoms in a mouse that we can now kind of test to see if we can improve. And we've been doing that with our data bank. Now we actually have over 65 tumors that we have in our clinical database. So of the research that we've looked at so far, just to touch briefly on them in the last couple of minutes, basically we've looked to understand why do some of these patients actually end up having hearing loss at the get-go before surgery and why do not. We've collected the local environment, CSF, to understand the macrophage microenvironment. And we found that actually the M1 macrophages are more ototoxic. And when a patient has more of these M1 macrophages in the tumor microenvironment, in the tumor itself, they tend to be with significant difference, have a higher rate of hearing loss. And so this may be a very interesting target to kind of prevent hearing loss in the future. As far as radiation resistance, again, it's a very complex problem. We've written about the different pathways that go into radiation of these kinds of tumors and why many different pathways end up causing radiation resistance. And when we look at our human cells that we've grown in the lab, we see again that there's a varying response of how they respond to 18 gray. Some respond very well and some don't, especially the actual cell lines respond very well to radiation where the human ones don't. When we looked at basically how they repair DNA breaks from the radiation, we could see that the RAD51, which is an expression of DNA repair, that it's always amplified when you give radiation, which is what's known. The ability for the 51 expression, which will kind of then help to repair this, is changing, which allows which shows the cell going into cell cycle arrest because of these breaks is much different in the tumors that are radio resistant than radio responsive. And so there is a subcategory here of these kinds of tumors that do respond well to radiation and ones that don't. And if we could kind of predict that before we radiate or at the time of surgery, then we could kind of tailor our surgery to understand when we should do subtotal resections, when we should do complete resections, or when we should be aggressive, when we shouldn't, if we know their radio response. And we recently just published this in Oncology. The question is after you figure this out, can you combine radiation with chemotherapy? And there's been multiple studies that show that in some cases, this does have a complementary effect in a synergistic way. And that if you combine this in some tumors, you can double the increase of tumor control, which leads us to the chemotherapy realm. Again, we look at chemotherapy exposure to these kinds of tumors. You would think that these are just not NF2 tumors, these are just sporadic vesicular carcinomas. And when we expose them to just one of our drugs, like a MEK inhibitor in this case, you can see such a varying response to these tumors. They're not all responding the same way, even though you would think these are simple tumors. But when we look at transcriptome and methylation, we could actually identify that the ones that are responding well to certain drugs, like a MEK inhibitor, you could pick that up in their methylation pathway. And so are there ways now that we could actually kind of sample these tumors and then predict which pathways we should be targeting? And I think that's the future of precision medicine for these kinds of treatments. Lastly is just looking at kind of gene therapy, which again we're not looking at here, but I just want to give a shout out to this nonprofit NF2 Biosolutions, which is raising money to try to do gene therapy for the NF2 patients. Surgery, obviously the last resort. Is there any way that we could do these surgeries more safely? We've looked at using fluorescent dyes such as sodium fluorescein to highlight the tumor and the nerve. And we look at it in vitro, we can see the tumor cells are obviously much more fluorescent than the non. And in an animal model, when we see again, we can see that the tumor cells are much more fluorescent than the non-tumor fluorescent cells. And when we ask surgeons to identify the nerve, the tumor, and the CP angle, they actually, with the fluorescence, did much better to identify all the critical structures than without. And so we're starting a clinical trial in humans looking at that now. So, we've built a great practice in the last few years. We've done over 65 acoustic neuromas by myself and my colleague, Dr. Din, and that's just a small part of our team here. We have multiple neurosurgeons and otolaryngologists. I'm going to kind of just through this in lieu of time because I'm a little bit over already. This is the team at the University of Miami that's done all of the research here that I've talked about today. Just a small part and a small cog in the wheel, but it's been a phenomenal experience. And I think that precision medicine for NF2 and vesicular carcinomas is going to be the future. And, but sampling the tissue and understanding which therapies are best for which patients are going to be critical. And it's going to really help change the paradigm for where we are today, which has really not changed much in the last 30 years. If you have any questions, here's my contact info, and I'd be happy to discuss further offline. Thanks.
Thank you very much, Professor Ivan, for this great talk. Actually, we are glad and honored to have the experience of Miami University. I don't know, Ricardo is here. Ricardo, can you hear me?
Yeah, I could give an introduction to Ashish. Dr. Shah is next. He's one of our preeminent graduates from the University of Miami program. He's an undergrad here, and then his residency program. He was a prolific researcher as well as clinician during his residency with over 100 papers published, I think actually 150, winner of multiple NIH grants, and now he's actually at the NIH doing a fellowship in neuro-oncology, and will be joining us back here at the University of Miami in the summer to focus on brain tumor clinical work as well as building our immunotherapy research area. And he's going to be talking about glioblastoma and some of the work that we've done together looking at supramaximal resection. Thank you, Ashish.
Thank you.
Thank you, Dr. Ivan. Thank you for having me. This is an amazing symposium, and I'm honored to be able to present here. And, obviously thank you to my mentors, Dr. Komatar, Dr. Ivan. They've been amazing mentors for me over the last, 10 plus years. And this work that I'm going to present today is kind of a culmination of all of this work that we're able to put together. And I think it's very relevant as neurosurgeons to be able to, to look at glioblastoma and think about how we can improve survival and how we can move the needle, because, it is an extremely difficult disease to treat. And I think this work kind of highlights, some strategies that we've used to improve survival for these unique group of patients. And I think some strategies that other people can employ as well at their own institutions. So thank you again for having me, and I'll kind of get started. As always, we always start out with like a historical perspective on, what it means to, resect these gliomas. And, I think 50 years ago, probably in the 1950s and 60s, there was a kind of a famous quote, I pulled from one of these articles, but basically they said solid gliomas present a fairly hopeless situation unless they're so situated that a lobectomy can be performed. That's either right frontal, right temporal, or right occipital. So, the kind of hopeless situation that neurosurgeons kind of have thought about lobectomies. And a lot of that was because the morbidity and operative mortality in operating on patients and doing a lobectomy at this time in the 1960s was nearly 50%. I mean, this is 110 patients, had operative deaths out of 211 surgeries. So you're thinking about the operative mortality of doing a surgery like this was extremely high. And it wasn't until, about a decade or two later that when the microscope came around that, the safety of doing these surgeries improved dramatically. And so they actually looked at outcomes at that time, to look at the difference between microscopic surgical resection of GBM versus kind of this, a lobectomy kind of approach. And really there was no difference. So in the 1990s, this concept of supramaximal resection kind of fell off the map. And it was kind of decided that, a microsurgical resection with tailored chemoradiation or tailored radiation would improve survival for these patients. And we kind of all know this kind of story, that, overall survival at this time was like around 12 months. But it wasn't until, a group out of MD Anderson and another group out of UCSF kind of reinvestigated this work. I mean, this is work from Ray Sawaya's group. And around 2001, they showed that the improvement in survival of resecting, over 98% of the tumor was substantially more than when you left a subtotal resection. And when you parse that out even more, Nader Sinai's group with Mitch Berger kind of demonstrated that, that survival benefit actually extends to about 78% resection. So this kind of showed us that, the more you resect, the better the outcomes are. And this has really been, showed in paper after paper after paper over the last, 20 years, that the more we resect, the better the outcomes go. And this kind of stopped with the idea that, okay, we can resect just the contrast enhancing lesion, and then we can give chemoradiation with a STU protocol. And that's just kind of where we are now. But if you look back in the literature, 50 years ago, Pat Kelly's work from New York basically demonstrated that, these glioma cells, infiltrate into the parenchyma at least 1 to 2 centimeters away from the contrast enhancing lesions. So what does that mean for us? Does that mean we should be chasing these tumors? Should we be chasing these infiltrating cells? And, I think it was kind of debatable on whether or not we should. And this is kind of microscopic pictures showing, these astrocytic malignant cells in the middle of this kind of bland, in the middle of this bland cerebral cortex. So what does this mean for us? It means that, maybe we should, as neurosurgeons, try to maximize the extent of our resection and maximize the resection of the infiltrating astrocytes to hopefully improve survival. And this kind of work was pioneered by Hugh Defoe's group in France, mostly in low-grade gliomas, demonstrating that, there was a benefit in overall survival for these patients when you did a supratotal resection in low grades. And this is even translated to glioblastoma and contrast enhancing gliomas as well, in several other groups. Recently, there's a group out of MD Anderson that showed that that resection of the flare, around 20% of the flare area, can improve survival significantly as well. This was recently published in the Journal of Neurosurgery. And this is also, kind of corroborated with another separate group out of Korea, demonstrating that in non-eloquent region GBMs, if you do a lobectomy, as seen here below, that the overall survival and progression-free survival improves significantly. So, in Miami, we're fortunate to have this big tumor volume that, is really made possible by Dr. Komatar, Dr. Ivan, and we're able to look at our experience and kind of see whether or not our survival outcomes were similar or even better than those reported in the literature with supramaximal resection. So we looked at, first we looked at our non-eloquent region gliomas, and this is kind of, the low-hanging fruit. These are patients who have non-eloquent region tumors that we can maximize the extent of resection in this area. And we noticed that there are in our lobectomy cohort, which is our supramaximal resection cohort, the overall survival was 30 months compared to 14 months, and this is after controlling for size and age. And this was published in the Journal of Neuro-Oncology, that the progression-free survival and overall survival for this group was significantly more than those in the lesionectomy or gross total resection group alone. These are a couple examples of patients who benefited from lobectomies. You see here on the right lobectomy versus the left, you can see a gross total resection group. So the lesions of the lobectomy group were significantly larger, and yet even despite that, these patients did significantly better when removing a rim of a normal brain or infiltrating tumor around the contrast enhancing lesion. And what's really important is that you don't have to do a humongous surgery to get to resect these kinds of tumors. I mean, this is very feasible, and this is published in Journal of Clinical Neuroscience, that you can actually do this kind of surgery, do a very small incision, do a very kind of keyhole approach, and do a frontal or temporal lobectomy through the small approach, and the patients can leave the next day from the hospital with a significant resection and good outcomes. So these are just a couple examples of that. But the main question that most neurosurgeons say, well, that's great, doing a lobectomy is feasible, but what if it's not feasible? What if it's in an eloquent region? And I think we've employed a strategy that awake craniotomies are kind of the rule, and not the exception. So if we can, we try to do an awake craniotomy to maximize the extent of resection when possible. And I think that's a really important strategy to improve outcomes for our patients. So this allows us to map out eloquent regions or functional cortices early on, protect those areas, and resect as much as possible, and respect as much as possible, and an infiltrating brain as possible to improve outcomes. This is an example of a kind of a motor strip glioma that we were able to resect. We were able to do a maximal resection on this area because we were able to do kind of an asleep motor mapping with MEPs and strips to be able to map out the motor cortex, protect it, and map out descending cortical spinal tracts to be able to resect this lesion and resect infiltrating brain at the same time. So this is just an example of different techniques you can use to expand and enhance the extent of resection for these tumors. But if you look at the literature, this idea kind of stops, when you think about eloquent region gliomas, because they're positioned in areas where you necessarily can't resect them, or you have to do a biopsy alone. And I think our institution has kind of validated that you can do these surgeries safely, do them awake, and maximize the extent of resection and maximize outcomes for your patients. So I'm gonna hopefully show you that, and hopefully convince you that this is definitely feasible. So we looked at our patients, and we had about 102 primary newly diagnosed GBMs. And the mean age of surgery was at 61, and we split them up into the patients who got gross total resection and those that got supramaximal resection. And we're trying to eliminate selection bias, because obviously the ones that got gross total resection, who knows if they're more closer to eloquent regions than the supramaximal resections, or what the reason was. So we kind of did propensity matching to kind of simulate a randomized clinical trial. So we matched for age, we matched for pre-op functional status, and matched for tumor location. And so then we ended up having a matched cohort analysis around 54 patients, 27 gross totals, and 27 supramaximal patients. And we basically looked at outcomes between these two patients. And it's really important that we controlled for all the different variables. So we made sure every single patient had the full STU protocol. All of the patients had volumetric analysis done, and they were all matched for IDH mutation, MGMT, and preoperative KPS. It was really important that all the tumors had to be at least between 1 to 2 centimeters of functional white matter, corticospinal tracts, or speech tracts as well. So this propensity matching is extremely critical when you're doing any type of retrospective studies, because you want to eliminate as much as possible the selection bias. So we perform this propensity matching, and as I mentioned, there's no significant differences in IDH mutation or MGMT methylation between these two groups. And this is just an example of a frontal glioma. This is one that got, a gross total resection at the top, and you can see the residual flare. And, it's unclear whether or not this flare has infiltrating tumor cells, but, I think I hopefully can convince you at the end of this lecture to show that this flare area does in fact have some infiltrating tumor cells, and resecting that flare and improve survival. So here on the bottom, you can see this is kind of a supramaximal resection of this glioma and resection of most of the flare in this area. So, two similar tumors, but two different outcomes. And when you look at the outcomes in this group of patients, the supramaximal resection group fared much better than the gross total resection group. The survival was around 21 and a half months compared to 15 and a half months in the gross total resection group. And progression-free survival also significantly improved as well in the supramaximal resection group. Now this is, estimating that you're removing at least 15 to 20% of the flare around the tumor as well. And so the volumetric analysis was extremely important in this group. And when you parse this out even more, you can see that the supramaximal resection group, if you divide it by the extent of flare resection, each iteration of improvement in flare resection improved survival outcomes. So you can see as you resect more and more of the flare from less than 40% did the worst, then if you go up 40 to 60% to 60 to 80% to even greater than 80% of the flare, that survival benefit improved significantly. So this kind of gives you proof in the pudding that as you resect more and more of the flare around the tumor, you're catching more of these tumor infiltrating cells, and you're improving outcomes for these patients, because the less tumor burden you have when you give chemoradiation, the better the outcomes are for these patients. So this is extremely important, I think, for us to look at, and to look at our patients to think how much can we expand our extent of resection. And I think the important thing here is that we're able to do this study because we're able to do these surgeries awake. We're able to map out the speech areas, map out the corticospinal tracts, and be able to see which areas we can preserve and which areas we can take in that sense. Obviously, there are several limitations to this kind of study. This is a retrospective study, so there's a significant selection bias. So for example, some tumors are more favorable for supramaximal resection. Some tumors are located directly in the middle of the motor strip. That our study is definitely limited by that. And we tried eliminating the selection bias by doing this propensity matching to be able to match for the KPS, the size of the tumor and the age of the patients. Our cohort involved multiple surgeons, so we have to control for obviously the surgical technique between the two arms, but and obviously we need long-term follow-up. The last thing that is extremely critical is this neuropsychological testing. You can imagine that removing adjacent functional cortex around the tumor may contribute to loss of neuropsychological outcomes. And in our series, the postoperative KPS did not differ from the preoperative KPS in both groups, but that doesn't mean that there may be some subtle neuropsychological issues in each cohort. So we're actually implementing a prospective kind of neuropsych testing pre-op and post-op for our patients to be able to distinguish whether or not the supramaxillary resection also has a detriment for neuropsychological outcomes or not. And a part of that also is doing some functional connectomics preoperative and postoperatively to see which white matter paths are being affected and which ones are disconnected after this type of surgery. So, these are kind of good adjuncts to do to make sure that your surgeries are also optimal and they also, result in good neuropsychological outcomes. Interestingly, that data is really not there right now in the brain tumor literature, and we're hoping to improve that significantly. So, I'll finish a little bit early, but the conclusions are basically, our propensity match study suggests that supramaximal resection for eloquent region glioma confers an added survival benefit compared to lesionectomy alone. And for patients with eloquent region GBM, a supramaximal resection should be considered as a primary surgical treatment in select patients if feasible. And this can be done with the use of awake craniotomy, motor mapping, SCPs to ensure that you have an optimal outcome. Patients can go home to post-op day one, and survival will be improved. And so, I think I hopefully drove that point home. And I'll leave you last with this last quote from this paper by Loyal Davis, but essentially saying that the story of surgical accomplishment in this most difficult group of intracranial tumors is not a pleasing one. It should challenge the surgical conscience and ability of every neurosurgeon. New methods must be devised to supplant the present crude surgical techniques of glioma removal. That challenge cannot be met by adopting procedures that hasten rather than slow the clinical progression of gliomas. So I hope that we can, this kind of motivated everyone to, rethink that our current paradigm for resection And I hope that, we can improve our outcomes. I want to thank, my mentors, Dr. Komatar, Dr. Ivan, for enrolling a lot of these patients. The residents, Dan Eichberg, Evan Luther, Victor Liu, Alexis, for all their work, and some superstar medical students, Long D, Anil, and Raghuram and Alexander, for a lot of their work on this data. This work is funded by in R25 by the NNDS and the UN BTI. So thank you again. I hope we can welcome you to Miami at some point in time.
Thank you very much for this great presentation. And I think somebody was raising hands. Alberto, are you here? Do you like to share in the discussion or to ask any questions? Alberto, you are allowed to talk. Okay, I think maybe he raised his hand by mistake, and I think we are a bit far behind the schedule. We now move to our next speaker. We are going to have a talk about surgery, enhanced recovery after brain tumor surgery. Dr. Nitesh Patel. Nitesh, are you here?
I am. Thank you so much.
Thank you.
Everybody can see my slides. I'm Nitesh Patel. I'm currently a brain tumor fellow here at the University of Miami with Dr. Komatar and Dr. Ivan. I'm originally from New Jersey. I trained for neurosurgery at Rutgers. First off, thank you so much for having us. I'm excited, of course, to be here at the University of Miami to do some additional training in the amazing brain tumor work they're doing here. I'm very grateful for my mentors and, of course, my colleagues. And that was an awesome talk by Dr. Shah, Dr. Ivan, and Dr. Komatar. You'll have a talk from Dr. Higgins, who's my co-fellow after this, to sort of show you guys a full spectrum of everything we're doing here at the University of Miami. I'm going to be talking to you guys about the sort of protocol we use here. It's a form of the ERAS protocol, enhanced recovery after cranial surgery. There's been quite a bit of literature already published on enhanced recovery and other surgical specialties, also in general surgery and, of course, in spine surgery. The literature for cranial surgery is sort of emerging, and we've been lucky enough to have a lot of our patients actually able to go through this protocol successfully. So first off, let's talk about the physiological response to surgery. Surgery itself, is essentially the patient are asleep, they're anesthetized. Body still reacts to surgery. Surgery itself is a form of a cascade of events is typically triggered, including cytokines and co-regulatory hormones. Muscle and fat breakdown ensues, and this is all in an effort to produce energy to respond. Acute phase proteins are also produced, which can trigger a response to injury, so to speak. And this sort of response to injury mode is affected in multiple organ systems. And this can result in pulmonary inflammation, injury, atelectasis, cardiac stress, renal injury, etc., affecting multiple organ systems. So we have to sort of think about this as almost like a marathon. Patients that typically go through a standard recovery are sort of in a green. They start off preoperatively and where they are in sort of the green figure here, and they go through a standard recovery and they make their way to a full recovery. Some patients are not a standard patient. They have other medical comorbidities. So our goal is to try to optimize these to get this red figure as close to this green figure as possible before we initiate surgery, which would be the starting point here. This way we can try to minimize their recovery time to try to match what a standard recovery, if not faster. So what is ERAS? ERAS is the goal is essentially to preoperatively identify which patients are fit for the procedure in mind, along with its expected recovery. ERAS protocols typically define 3 phases of care in which a series of small interventions, small ones, can produce big results in an additive effect. Preoperative, intraop, and post-op. Each of these phases of care will have small aspects that can be fine-tuned. Protocols have been developed using an evidence-based multidisciplinary approach. Over the last decade, their use has expanded from general surgery all the way into neurosurgery and other subspecialties. So for neurosurgery, our spine colleagues here at the University of Miami already took a look at ERAS and published on it extensively early on. This is a paper from Dr. Wang, who was sort of talking about all these interventions that you can take. And you can see in this figure here, pre, intra, and post-operative, small things, patient optimization, talking about alcohol, making sure they're not anemic, talking about preoperative nutritional evaluations, et cetera. And then even, intra-op and post-op, including early mobilization and physical therapy, early oral nutrition. These seem like obvious things, but you'd feel that if you were to check off all these boxes, you'd only make a marginal improvement in their risk reduction by maybe 0.5% or 0.25%. But if you can fix 10 of these factors, you're talking about a 2 to 3 to even up to 5% risk reduction. The ERAS approach itself, it challenges more traditional models of care. These were often labeled as fast track methods early on in the early general surgery literature. But the evidence was clear. And you can see here, fast track versus traditional, fast track being ERAS protocols for things in general surgery, inguinal hernia repairs, going from traditional overnight to even just a couple hours, lap choles, 1 to 2 day hospital stays to same day discharge. And these can be directly translated into the neurosurgical world. This is our own institution's use for a spine surgery ERAS, and you can see there's significant reduction in length of stay, ambulatory distance, Zofran use, opiate use. And, sort of what we can do is, we can sort of look at this diagram and identify small but important steps that can sum up to a much larger effect. The red asterisks sort of mark off a few elements that can be easily improved anywhere, even when you don't have fancy equipment or resources. And even if each of these factors reduce overall complication risk by 0.25%, 0.25%, 11 of them, which are marked off here, could lead up to a 3% risk reduction. So it seems that an ERAS mindset is great to have, but patient selection is pivotal. We assess each patient's level of function using KPS. Generally, a KPS greater than 70. We factor in careful preoperative clearance, including correspondence, as Dr. Combs already talked about. Of course, it's important to correspond with their primary care providers and all their care providers in their health circle, but it's also important to identify any active issues they may have. Patients may not always state what they have actively going on. It could be simply simple as taking a baby aspirin or taking an anticoagulant. The patients don't necessarily realize how critical that is to know about. And of course, taking in the role for things like preoperative embolization, if you're going to be considering that, and vascular imaging, if you're suspecting involvement of vasculature. So these are typical cranial surgery logistics, at least where I trained. We weren't doing the ERAS protocols necessarily like the way we do them here at University of Miami. You typically have for an office visit, for example, for a referral, you have an office visit, you have surgery scheduled 2 to 6 weeks later. In the meantime, you get medical and cardiac clearance, so workup, additional images, labs. The patient comes the day of surgery at 6 a.m. for arrival. Then, of course, they have post-operative pain control, et cetera, progressive PT. They leave in about 4 to 5 days max, typically. Now, that's for an office setting, in a traditional setting. Now, an urgent, semi-urgent kind of case in a traditional non-ERAS approach would be an ER visit would occur, sort of surgery scheduled within 3 days. You get rapid clearance in the hospital, surgery happens. And then, of course, patient goes home at some point within a few days. Here's some factors that you can immediately improve along these timelines from an ERAS standpoint. If a patient's here in the office, well, make a way to have them scheduled for surgery faster. Just as Dr. Komatar says, they shouldn't be scheduled weeks out unless you have time to wait. A patient with a brain tumor is not going to wait. It's that simple. A patient with a brain tumor knows they have something growing in their head. To them, even if you tell them it's a benign lesion, slow growing, they're going to be thinking, until you do that surgery, they're going to be thinking that thing's going to keep growing and basically start pressing on their brain. And they're going to come up with all kinds of things that they can correlate to that. Rapid correspondence with referring doctors. Again, faxes are just not sufficient. Texts and emails are the fastest way to go, and in phone calls. If you could admit the patient the night before, it allows for a smoother pre-op. The patient doesn't have to wake up at 4 a.m. to get to the hospital at 6 a.m. Instead, they can come the night before, have their IV set up, get their MRIs if they need for preoperative workup, and have a full night's rest. And then when they wake up, they simply roll down to the OR and have their surgery done. And then, of course, the post-operative, which can reduce length of stay significantly. If you have physical therapy, nursing staff, along with your multidisciplinary team, all fine-tuned towards getting the patient home as fast as possible, safely, of course, you can maximize your outcomes. You can get a patient that would typically stay in most institutions for 3 to 5 days can go home the next day. For urgent cases, again, work with the OR to find a reasonable scheduling slot. Rapid correspondence, typically using inpatient physicians in your own institution, and of course, have your backup plan set. But the postoperative phase is the same. Sort of just, I'll sort of go through this pretty quickly. Again, as I said, alluding to tuning up for a marathon, you have to really discuss blood thinners, pain control, glucose control, and center spirometry. These things should be discussed with the patient very early on so they understand this. I think pain control is critical. Patients should understand that they're going to have some pain postoperatively. At the end of the day, you are making an incision, even no matter how big or small it is. So some tenderness or some discomfort may be expected. And if the patient knows that, more often than not, they understand, okay, I'm going to have a little bit of pain. I don't need to load up on pain medication that I don't need. And you can actually get these patients out of the hospital faster and back to their normal lives. Let's talk a little bit about operative considerations for approaches. Here's sort of an array of different approaches, that can be used. Endoscopic, keyhole, tubular, stereotactic biopsy, laser ablation, and of course, transcortical approaches. We try to minimize our incisions here, try to keep things linear in terms of incisions, try to minimize soft tissue disruption, and of course, achieve our goal through the smallest opening possible. Some fundamentals, we use neuronavigation for all cases. Neuromonitoring is used very judiciously, but if we need it, we use it. We sort of keep in mind what we should expect for a degree of resection. For a benign superficial tumor, gross total resection should be the goal. For a benign deep tumor, be conservative. Obviously, if you can get the whole thing, great, but don't be a hero because you could potentially hurt the patient. For a malignant superficial tumor, of course, gross total resection is the goal, but you got to respect anatomy and function, especially for primary gliomas. And then for malignant deep tumors, we have to be very careful in these cases. The goal is to not disrupt any tissue, but you also want to achieve some sort of a surgical outcome here. So you can consider biopsy and consider using laser and or radiation. For our endoscopic cases, hopefully this video plays, but we use the spyway system here. We use Axiom, so we don't have to pin our patients. This sort of minimizes any sort of scalp pain from post-pinning, along with blood pressure changes and muscle spasms. We minimize anatomic disruption. We carefully tailor our corridors, as far as turbinate takedowns go and nasal septal flap utilization. We're very careful in terms of using them. Also the mucosa, where I trained versus here, the amount of mucosa that's stripped in the nasal cavity is far less here because they're very focused on, you're just focusing on what we need to open to get to the tumor. And then, of course, keeping in mind superior and inferior arachnoid folds in front and behind the tumor itself. It can easily lead to a CSF leak, and then that can make the case very difficult. And then, of course, identifying gland position early on your preoperative MRI. Here's an example of the spyway tubes that we use here. I'll sort of go through this a little fast. These are inserted into the nares bilaterally, and they allow for a nice working corridor without, as you go in and out with your camera or your instruments, you don't bump into the mucosa and the nasal cavity, which makes it far less traumatic. For craniotomy approaches, we tailor our craniotomies very carefully. Be mindful where the frontal sinus is, the orbit, the periorbita, and of course, it's always better to expand the craniotomy than to excessively retract. Especially for frontal tumors where you have to sort of sneak in underneath the skull. You want to avoid any sort of delayed venous injuries, which can happen. You may not realize it intraoperatively, but a couple of days later, the patient's more and more confused, and you get a scan and you realize there's a venous infarct. For middle fossa cases, of course, be mindful of your air cells, wax them off as needed, along with the venous sinuses. And for the P fossa, same thing. We use the Vicor tube system quite often here. The nice thing about the tubular system is it balances visibility, and they sort of allow for a reach for deep-seated targets. They're thought of as being fiber tract splitting, but more than likely there is a degree of cortical subcortical injury. I think most people acknowledge that. However, in contrast to traditional paddle retractors, the force is applied circumferentially and retains a cone of work. Obviously, not the solution for everything, as trajectory change is a challenge, but allows for a small cranie and therefore a smaller incision. Here's an example of a case we did entirely through a tubular approach with discharge home the next day after surgery. Patient had surgery. Next morning, they woke up, had breakfast, worked physical therapy, and went home by that afternoon. This is all through our ERS protocol. For the laser biopsy route, for a deeper seated lesion, which, will be higher risk to take out with open surgery. And we sort of follow this sort of algorithm here. a deep-seated lesion. Is it greater or less than 3 centimeters? There's significant edema, and you can work through this short little decision tree here to decide if radiation is better, resection is better, just simply a biopsy or a biopsy combined with laser. It's sort of very high value when it's coupled together, especially laser and biopsy. It gives both a diagnostic and a therapeutic outcome, and the entire procedure with the laser and biopsy can be done in sequence with the ROSA robot with a 2 millimeter incision. I mean, just a stab incision. And of course, patient can go home the next day. For transcortical cases, we identify the shortest distance. Navigation is usually most useful until the lesion is encountered, as the anatomy typically changes after that. We carefully plan our cortical entry, of course, as most do, and we, sort of avoid taking veins and vessels as a rule. Dr. Komatar's, what was a little different here is that he is very specific about when bipolar cautery is used. A lot of his work is simply done with a suction and a bayonet. With the bipolar, it seems like it's focused, and the heat, seems like it's only at your target. However, the heat can spread, and it can cause for cautery is sort of critical. As Dr. Shah said, awake surgery is a rule, rather than the exception. This is an awake case that was done here a while back, and we had the patient sort of singing. So we tend to obviously have a good team here. We tend to have fun in the operating room to make sure that our experience, not only as a team, but as providers, is optimal for the patient and the patients are comfortable. Awake craniotomies are typically big events at most institutions. We just do so many here at the University of Miami. It's fairly common, and the logistics are very smooth. Our team is very fine-tuned towards it, and it's a combination of using an approach where we demystify this sort of awake craniotomy concept. Of course, patient tolerance, positioning, simulation plans, and sort of plan testing are all critical. And we just tend to discuss these with the patients in the office so they understand what to expect when they are awoken during surgery. For operative planning, positioning is critical. If supine is in any way reasonable, do it. We try to limit any sort of stress on the patient's neck and shoulders during positioning, as this can lead to muscle spasms, et cetera, postoperatively, which can actually lengthen their hospital stay. They may tell you they have all this pain, but it's actually from the fact that they were positioned in a very odd way, and that led to a lot of muscle spasms. So the incision's not hurting them, the surgery is not hurting them, it's the positioning. So we try to maintain as neutral of a body position as possible. We try to always approach cases supine if needed. However, if need to go prone or anything different, we try to maintain a normal anatomic alignment. Of course, surgeon position access and position are also important, so we have to keep those in mind. Incision planning and soft tissue work, we try to choose well-concealed areas when able. The shortest linear incision is most often best. We minimize hair shape to almost none. Staples can be used to help pull hair away from the incision. However, we don't necessarily close our incision with staples almost ever. And of course, avoid cutting craniofacial muscles unless mandatory, especially the temporalis muscle. Absolutely critical if you're doing a frontal approach and you do a terional incision, you don't necessarily need to take the temporalis. It's critical to understand that, because that can lead to a lot of facial pain and also pain when they chew. Patients want to eat after surgery, and if they can't eat, they're going to be unhappy. And of course, when you do this, though, keep in mind where the frontalis nerve is. As far as bone work goes, avoiding sinuses, air cells, the mastoid, this all goes without saying. Don't take off more than necessary. For these cases, traditionally, some places would be doing bilateral or bifrontal cranies. We took out both of these tumors using a unilateral terional approach. Some other operative considerations: corridor creation and pathology handling. We avoid bipolar work deep in the surgical bed, as I said earlier, especially beyond a centimeter deep. For senior residents, it's sort of good to slowly develop an understanding of the sub-peel technique and its value for protecting sulcal vessels living in the sulcal spaces. Other things, as far as closure, duroplasty closure, we try to achieve a watertight closure or scaffold. sometimes only a scaffold is feasible. Regardless, we use a multi-layer approach. We use a lot of the amniotic membrane here, the dehydrated amniotic membrane, which is combined with bovine collagen duragen, and sort of has been shown in our prior published series to provide lower rates of CSF leaks and a good heal outcome. I recently did a revision cranie from a recurrent GBM, and it was one we used amnion. And I recall when I opened up the bone flap, I mean, it looked pristine, almost as if it was never opened in the first place in regards to the dura. For skin closure, we're multi-layered. We use absorbable suture essentially in every case. And this is critical for the telehealth era. With the pandemic, a lot of our patient visits have moved to a virtual space. So patients don't necessarily get to see us in person. And, this sort of has helped us utilize more of these absorbable sutures, so they don't have to worry about coming back to an office to have the sutures removed. Other things, post-operative considerations, anesthesia and pain control on post-op day 0, meaning this after surgery, limit opiate use, emphasize these post-operative care plans. And we talk about these things pre-operatively in the office. We tell patients, you're going to go home the next day. We're going to limiting pain medications because we want to make sure that you're not overdosed on pain medication. We want you working with physical therapy right away. And most patients go in with that mindset and they're motivated post-operatively to continue it. Post-op imaging, we've been lucky here. Our MRI logistics here allow us to get an MRI the same day after surgery. This can be done almost anywhere as long as you have, again, multi-team buy-in. Hospital administration, along with your MRI team, all have to basically buy into understanding that the goal here is not necessarily to make the surgeon happy with an MRI, it's to get the patient home faster. And the faster the MRI happens, the faster the patient go home. We make these collages Dr. Komatar already talked about. It's a great tool for rounds and correspondence with the referring providers. Some other consideration from medication standpoint, anti-epileptics, be very clear with your team regarding endpoints, indications. Steroids, make sure the entire team is aware. Here's our protocol of what we use for supratentorial, infratentorial, and our goals as far as the tapers versus endpoints for eloquent and non-eloquent cases. I won't just go through that. You guys can read that as well as I can. Antibiotics and anticoagulation and pain control. It's important to be consistent across this and not vary from patient to patient. Otherwise, your team gets confused and then that can lead to complications. Other things, as I talked about before, patient has surgery, next morning they have breakfast. We want them working post-breakfast with physical therapy and sort of reminding them in the morning that their goal is to go home by the afternoon, back to their own bed, back to their own food at home, which most patients find a lot more comfortable than eating and sleeping at a hospital. Follow-up, as I said, telehealth works well for patients that are geographically distant. And, with our practice, we're having patients come not only all over from Miami, but all over from Florida and all over the country and world, including South America. So the telehealth approach works great, especially with absorbable sutures. And it sort of allows rapid correspondence with the patient and their providers because you can, sort of touch base real time. And we try to do this within two weeks. Here's some of our data from our ERAS for cranial surgery same-day discharge. So we've gotten to the point where our protocols are fine-tuned enough where we feel comfortable discharging a patient after the surgery same day. So they'll have their surgery in the morning, they'll have dinner at home at night. And we do some very select cases, for convexity cases, for smaller lesions, metastatic lesions, whatever it may be. And over the last 12 months, we've done about 70 plus cases. I think we're approaching probably 80 or more now, if not close to 100. And our readmission rate was about 5.5%. That translates to about 3 or 4 patients total. Of those 3 or 4 patients, none of them came back for a neurosurgical issue. The reason included things like a urinary tract infection, an upset stomach, nausea, vomiting, et cetera, but no neurosurgical reasons. And we've, been able to validate our ERAS approach using this data. So with that, I know we're sort of short on time and we're running behind, so I'm just going to finish up. I just want to thank our brain tumor team here, of course, my mentors, my co-fellows, the residents here who've been amazing to really bring us in as family. We truly love coming in every day, and it does not feel like work. It really is a family. It's truly a very fortunate opportunity to be here. And thank you guys so much for having us.
Thank you for this interesting presentation. And now we move to our next speaker. Would you please introduce your colleague?
Absolutely.
Thank you.
So
Thank you.
our next speaker is Dr. Dominique Higgins, who comes to us from Columbia University. Dom trained at Columbia for neurosurgery residency and also has his PhD and his undergraduate education from Stanford and Mayo. He's an amazing guy. I love working with Dom. You know, I get to see him more than I get to see my wife. So without further ado, Dom, all you, go for it.
Right. Can you see my screen?
Yes.
Thanks, and thanks for the extremely kind introduction. I love seeing you as well. I can see you more than my wife. I'll be talking about dietary regulation of ferroptosis and glioma, in glioblastoma, and specifically work from Columbia that we're partnering at the University of Miami to continue as well. Just for disclosures, there's a provisional patent around this therapy that we're developing, but no direct financial conflicts. So just an overview. I'll, for the sake of time, skip on the talk about glioblastoma. Dr. Shah and Dr. Patel already gave a wonderful overview of the surgical aspects of it and clinical side of things as well. But we'll talk about, programmed cell death, this umbrella of cellular mechanisms that result in cells dying, apoptosis being probably the most popular. But a novel method under that programmed cell death umbrella is ferroptosis, which was discovered by one of our collaborators at Columbia. And I'll go through the pathway a bit, but the key building blocks to take away are cysteine, methionine, are the amino acids that keep the pathway running. And then GPX4 is the enzyme where they converge for cellular machinery. And so what is ferroptosis? It's iron-dependent lipid peroxidation utilizing Fenton chemistry. It's important for many developmental and pathological processes, and it's a critical cellular protective mechanism against reactive oxygen species and stress. And like I mentioned, it's dependent on sulfur-containing amino acids, which are specifically cysteine and methionine. You can see in the flow chart on the right that methionine can be converted into cysteine, and then they both are salvaged through the taurine-hypotaurine pathway. And GPX4, glutathione peroxidase, is the enzyme that is at the core of this pathway. Cysteine and methionine converge to form glutathione peroxidase, and it's used to clear lipid reactive oxygen species in the cell. By inhibiting it, these lipid species go on to induce ferroptosis. And so by targeting ferroptosis, there's different classes of pharmacological agents that you can utilize. I'll focus on the class 1 and 2 drugs that either target the system XC, which you can see in the top right. This is a cellular antiporter that pumps out glutamate and allows cysteine to come in, which is ultimately converted to cysteine, which can be used to form glutathione. And sulfur-containing amino acid restriction has had some precedence in cancer therapy recently. 2 high-profile papers showed that by dietary methionine restriction, you can enhance cancer therapies, and methionine and kynurenine can also be effective in glioblastoma. And more recently, one of our collaborators at Columbia showed that cystinase enzyme can deplete cysteine and induce pancreatic tumor ferroptosis to improve survival in the mouse model. Given the limitations of the blood-brain barrier, though, we chose a different strategy by using dietary mechanisms of depriving the tumor of cysteine and methionine. So our thought is that this can enhance sensitivity to ferroptosis. And just a reminder of the overview of the pathway. So by depleting cysteine and methionine from the cell, you have less glutathione available. And so glutathione peroxidase, which uses glutathione as a substrate, can't be effective in clearing these lipid species. And as a result, you undergo ferroptosis. And so to test this out, we used a cell model widely used in the Bruce Cano lab at Columbia, along with some human lines as well. Testing one of these drugs, as I mentioned, the class 2 that directly inhibits GPX4. And by treating them with RSL3, this GPX4 inhibitor, we see that there's a significant cell death in a dose-dependent manner on the left. And in the middle panel, when we deprive the cells in the media of cysteine and methionine, there's baseline cell death, but they're also exquisitely more sensitive to RSL3 at all doses. This is rescued by ferrostatin, which is an inhibitor of ferroptosis, which demonstrates that the pathway is the cell death happening is ferroptosis specific. And then here's a video showing that lipid peroxidation is occurring. It's using a fluorescent marker of lipid peroxidation called BODP-C11 on the left, or glioma cells treated with RSL3, the GPX4 inhibitor, and using live confocal microscopy, we can see that there's an increase in the green signal, which indicates lipid peroxidation. And on the right is in the presence of ferrostatin, the inhibitor of ferroptosis, and you don't see the lipid peroxidation. And here's just a timestamp of the video I just showed. And then when we do flow cytometry, comparing treatment with RSL3 at a low dose, you don't see any effect, similarly with the inhibitor. But a low dose of RSL3 plus the cysteine methionine deprivation is enough to result in BODP activation comparable to high dose RSL3, showing us that the CMD or cysteine methionine deprivation enhances lipid peroxidation. And this is a quantification of that study as well. And so we wanted to see whether or not these GPX4 effects are specific to RSL3 or if it's broadly applicable. So we used a independent agent, ML210, which also targets GPX4. And we see a similar curve as well, that the cells are sensitive to cell death by ML210, inhibiting GPX4. This is also rescued by ferrostatin. And on the right, we test other rescue agents that specifically inhibit necroptosis and apoptosis, which are some of the other cell death pathways that I mentioned at the beginning. And when you combine RSL3 with either of those agents, you don't see rescuing of cell death, but only with ferrostatin, the ferroptosis inhibitors, and it's suggesting that the cell death happening by RSL3 is specific to ferroptosis. And so next we looked at the hallmark transcriptional changes by using qPCR, and we see that in response to cysteine methionine deprivation alone, we see an uptick in the traditional transcription factors that are upregulated in response to ferroptosis, namely CHAC1, PGS2, and SLC7A11, suggesting that the cysteine methionine deprivation is priming the cell to undergo ferroptosis by its traditional means. And so next we looked at the metabolomic profiles of the cells treated with CMD, and we can see on the left when we do the proteomic analysis of the cells, either control or CMD, there's distinct profiles by principal component analysis, and we do pathway analysis of these cells. We see that the most upregulated pathways are, not surprisingly, cysteine methionine, in addition to glutathione and taurine. And then just kind of teasing out these specific pathways, we see that the components that feed into glutathione are all downregulated in response to CMD, as well as the salvage pathway, taurine, is also downregulated, suggesting that we're having a profound effect on the pathway at all levels. And then we do a flowmetric analysis of glutathione levels, specifically reduced glutathione in response to treatment across 4 different cell lines. 3 mouse and 1 human. We see that there's significant downregulation of reduced glutathione in response to cysteine methionine deprivation, also consistent with a priming effect of the diet on the tumor cells. And then using a seahorse analysis to look at the oxidative phosphorylation of the cells in response to cysteine methionine deprivation, we see a global suppression of the respiratory chain in response to CMD. And then next we wanted to test in vivo whether or not the diet alone was effective in terms of affecting survival of the mice. So we took mice and injected them with our tumor cells that we used in our in vitro assays, and switched them to either control or a cysteine methionine deprived diet at day 7 and test and assess for survival. And we see a modest but significant improvement in survival with simply just a dietary change alone in mice injected with these gliomas suggesting that the in vivo environment as well is being affected in the brain to improve survival. And we then took the tumors from these mice, either from control or cysteine methionine deprived mice, and use DESI-IMS, which is kind of an imaging-based mass spec technique to look at the spatial changes with regard to lipidomics in the tumor cells versus control cells. And we see distinct lipid species and fatty acid species between the control and the cysteine methionine deprived tumor sections. So in summary, we demonstrate here that RSL3, this GPX4 inhibitor, induces ferroptosis in gliomas. Cysteine methionine deprivation enhances ferroptosis in gliomas and prolongs survival. And CMD results in specific lipidomic and metabolomic changes, which can sensitize gliomas to ferroptosis. And so our translational strategy is now underway to try to see if we can move this into more of a clinical setting to apply dietary deprivation to glioma patients. This is a large undertaking involving a lot of different specialties and expertise, but we're looking forward to the next phase and hope to be able to share with you that data in the near future. And so I'd like to thank a lot of people that helped. First of all, thank you for inviting us to participate in this wonderful webinar, and thanks to the University of Miami team for having me here for the year. It's been an amazing year, learning a lot from a clinical standpoint with Drs. Komatar and Ivan, in addition to the strong research environment here at University of Miami. That's looking forward to the next phase of my career as I get my own lab and clinical practice started. I'd like to thank the Columbia team, the Bartoli lab with Dr. Bruce and Dr. Kunal Pavan, who's now a resident at Columbia, who spearheaded this work along with myself during publication, and Angelina Hawkins Masis, who did a lot of the work with me. Who's also a resident who has an expertise in this as well. Ben Stockwell and Simon Chang and Mark Siegling as well. The Columbia core that are critical in terms of helping to get this off the ground. And we'll take any questions, or we can have Alexis give his talk next.
Thank you, Dr. Higgins. I think we can have some questions after our last speaker. Alex, would you please introduce Alex?
And I'd like to use Dr. Alexis Morel. He's a fully trained neurosurgeon from Argentina, and he's been at University of Miami now for about 2-3 years. He's our research coordinator and valuable piece of the clinical research and basic science research arm of the brain tumor research program here. Works tirelessly. Is a great guy to hang out with, and looking forward to hearing his talk as well.
So thank you, Dom. Thank you for that. And thank you, Professor Nasser, for the invitation. It's a great honor.
You.
So I'm going to share my screen. Can you see my screen?
Yes, it's good.
Perfect. So yes, thank you, Don, for the presentation. My name is Alexis Morel. I'm one of the research fellows here at the University of Miami, and I would like to present this presentation that is called Non-Traditional Endocrine Areas, What's Below the Tip of the Iceberg. So I have no disclosures relevant to this talk. We are going to discuss a few concepts about connectomics, traditional and non-traditional endocrine areas, concept of brain networks and DTI, our experience, and surgical applications, and some future directions. So historically, the term neurologic deficit in neurosurgery has been associated with the concept of focal neurologic deficit, defined as a set of symptoms or signs in which causation can be localized to an anatomic site in the central nervous system. And then we call eloquent brain area the part of the brain that, when damaged, can produce a in general, define neurologic deficit. In contrast, when a neurologic function is altered but the cause cannot be localized to a specific anatomic site, we generally use the term non-focal neurologic deficit. As an example, can be altered mental status or confusion. And following the same logic, when a part of the brain is removed and we don't see a neurologic deficit, we call that part the brain non-eloquent. But what about higher cognitive functions? Can we use the same approach? I mean, if we remove a part of the brain and the patient becomes less intelligent or cannot socialize, can we consider that part non-eloquent? So balancing the quality of life and the oncologic outcome of our patients is the cornerstone of neurological oncology. If there is no quality of life, doing a perfect resection is just not justified. But the question is, how are we trying to preserve the quality of life? Are we trying to save these functions, or we are also trying to save these functions, which are part like which are higher cognitive functions, and they are not discussed in neurosurgery very often. So we must be honest with ourselves and recognize that a patient that can talk, see, and has no gross motor deficits is not necessarily neurologically intact. The neuroscience literature is very clear, showing that patients with brain tumors have many higher cognitive functions altered. So why should we care about this as neurosurgeons? We face epic problems as brain tumors, traumatic brain injury, chronic pain, coma, stroke, mental illness, dementia that will affect 25 or 40% of humanity in total. And all these problems are extremely complex. And we are facing these problems with limited verbal tools, some history, neurological examination, images which show the brain shape and not the function, and some lab tests. Even if you have neuropsychological tests in your center, you're using between 20 and 30 data points in a 25 million dimensional problem. In other words, it's like the fight is not that fair. So we can see that this is what we have used in the past. We use indirect vision to try to diagnose brain tumors. Now this is what we are using. We can have a very good picture of the brain in terms of anatomy and some functions. But what we really need is the brain wiring diagram, the functional map of the brain, and how can we apply these concepts in the clinical setting. So we do have an information gap. We need to, and how can we close that information gap? So we basically need three things. We need to standardize the complex functional anatomy of the brain and understand what is behind the connectome. We need efficient tools to process and visualize brain networks and subnetworks. This is where artificial intelligence, machine learning, and deep learning are really useful. And we need to understand how to navigate the connectome in real life. So let's start with the first one. So basically, the connectome is a comprehensive description of the connections between every gray matter location and every other gray matter location at the microscopic scale, as analyzed using non-invasive neuroimaging. So this is basically a map of the connections of the brain. And the connectomics is science concerned with assembling and analyzing connectome datasets. In summary, connectomics is the scientific tool we use to analyze the brain connectome. A major contribution to this field was started with the Human Connector project that began actually 10 years ago. The objective was to characterize human brain connectivity and develop improved neuroimaging tools, methods, and they acquired more than 1,000 high-quality multimodality MRI datasets and created a novel multimodal parcellation scheme of the human cerebral cortex. After creating the parcellation scheme, they trained a machine learning classifier to recognize each cortical area, detecting more than 95% of these cortical areas in new individuals. So this project created a new parcellation scheme, a new organization of the cortical surface of the brain, just like Brodmann did it more than 100 years ago. But instead of using the cytoarchitectural organization, they use a connectivity-based multimodal approach, more consistent with modern neuroscience. So by standardizing the functional nomenclature, it's now possible to advance the field of brain mapping and how the brain is wired and how injury can affect function. So this new understanding of the human connectome is in correlation with other concepts that have been around for a while. So let's use example of the language network. The historic model was centered up, in two areas, Broca and Wernicke, and one major tract, which is the arcuate fasciculus. We can locate these eloquent areas using intraoperative mapping and one track with chartography or with intraoperative mapping. But now we know that the language network is way more complex. It's more like this. It's really a network, and we cannot analyze this whole brain network with DTI only. We need better tools to understand the role of every part of the network in language function. So as it happens with the language network, there are many other networks with multiple parts and functions. And if we want to preserve these functions, we must look beyond the tumor and include the brain connectome as a whole. So using a very simple analogy, let's say that we are still in the boat of brain tumor surgery and we want to get to the house of onco-functional balance. And if we only see what is in our current site and we ignore what is below the tip of the iceberg, this is what is going to happen. We are going to hit something we cannot see. And just, it happened with the Titanic, if we would crash our boat, hitting something we can see. The same thing happens when we cannot explain the outcome of a patient that can talk, can walk. The patient is supposedly neurologically intact, but the patient can work, can't socialize, and the patient has become a burden for the family. So the first question is, what is below the tip of the iceberg in a patient with brain tumor? So, and to answer that question, we knew that we needed efficient tools to process and visualize brain networks and subnetworks, something that can be used in the clinical setting. So here at the University of Miami, there are more like 1,000 brain tumor surgeries per year. So spending many hours segmenting multiple studies was not very efficient in terms of resources or time. And right now we have a great understanding of the functional areas of the cortex and the connectome of normal patients. I mean, the wiring diagram. But the problem is that most brain maps, they try to fit or deform this atlas. One example, as I said before, the Human Connector Project, onto a specific patient's brain based on shape. Most previous cortical brain mapping techniques have tried to make personalized maps of the brain by assigning brain areas to functional units based on their location in a three-dimensional space. This is obviously not achievable in patients with brain tumors because of this anatomical deformity. How do you fit or deform an atlas onto a brain tumor patient's brain? Extreme shape deformity strains the system beyond workability and cannot be used in real life. This is really hard to do. So almost a year ago, we started using a new platform that is called QuickTo. This is a cloud-based, fully automated platform that uses unsupervised machine learning techniques, meaning that it is totally automatic. It is based on the Human Connector Project parcellation scheme, is FDA approved for network analysis, and it uses a 2:1 with contrast, as you can see here, and a high resolution DTI sequence to map and visualize brain networks in patients with brain tumors. It also has edema correction algorithm that is pretty accurate. You can see here some examples. The sensory motor network here with fibers crossing the tumor, the visual network pushed by the edema, and the language network also pushed by this very large tumor with extensive mass effect. So now that we have the tool to start exploring what is below the tip of the iceberg, and how can we understand how to navigate the connectome in real life in patients with brain tumors in a clinical setting? So we did our first study and we wanted to characterize brain network damage in patients with intraaxial brain tumors. So we categorized the integrity of 9 large-scale networks. Those were the language, sensory motor, visual, ventral attention, central executive, default mode, dorsal attention, salience, and limbic. Networks were correlated with preoperative clinical data, and we divided all the networks in 2 groups: language, sensory motor, visual, and ventral attention networks, and we call them traditional eloquent areas, and the central default mode, dorsal attention, limbic, and salience, and we call them the last group, non-traditional eloquent areas. So briefly describing the brain networks we analyzed, let's start with the most common ones. So we have the visual and sensory motor networks, which are familiar to most of you. The visual network is responsible for visual and sight processing, and it has the some streams. One of them is actually the ventral stream, which is also called the what pathway. The dorsal stream is the where pathway, and the lateral surface, which is involved in higher order visual processing areas. The sensory motor network is in charge of sensing physical inputs and performing motor actions, as you know. But it's not only the primary motor and sensory areas, but also the SMA and ventral and dorsal premotor areas. Then you have the language network, including many subnetworks related to different functions as articulation, phonology, syntax, lexical access, repetition, reading, verbal, and non-verbal semantics. And so far, we are familiar with these networks, and we try to evaluate these areas when we are doing surgery, mostly by doing intraoperative mapping. The next one is the ventral attention network. This has a function that we're also familiar with, as this network is involved in visual spatial orientation. And when this network is damaged, it can cause hemispatial neglect. It is also involved in stimulus-driven attention and other special attention functions. For example, if you're watching TV and we hear a loud noise in the kitchen, our attention reorients toward that loud noise. But now we are starting navigating uncharted waters. This is what is below the tip of the iceberg. No one can argue that the previous networks are eloquent areas, but what about these? The first one is the default mode network, which encompasses the medial prefrontal cortex, the posterior cingulate cortex, the precuneus, and lateral and median temporal lobes. This network is a task negative network, which means that it's active when you're not performing any active task. Some examples can be rest, when you're sleeping, when you're mind wandering, when you're using your imagination, when you are basically using your internally directed cognition. It also coordinates with other networks, and when damaged, can cause dysfunctions that may contribute to difficult processing social situations and information. It also can be impaired in autism, schizophrenia, radiation-induced cognitive decline, Parkinson's disease, and many other pathologies. The dorsal attention network is involved in externally directed cognition, meaning that allows you to focus on something specific that is external to you. That can be, for example, a movie or a lecture. And when damaged, it is associated with neuropsychiatric disorders like schizophrenia and attentional and sensory disruptions. The central executive network is extremely important for higher cognitive functions, and it is basically the difference between a child and an adult in terms of like how mature the patient is. It's active during tasks and decision making, and is critical for general intelligence. It is modulated by the Celiac network, which is the next one. And this is one of the most interesting networks, at least for me. One of its main purposes is to modulate other networks, new stimuli, and attention. It monitors the external world and decides how other brain networks react to new information. Lesions are related with akinetic mutism, dementia, schizophrenia, and other mental disorders. As an example, we can see how these four networks close together to perform everyday activities. The default mode network commands the internally oriented cognition. The central executive network is responsible for the goal-oriented cognition. And the dorsal attention network is responsible for the externally oriented cognition. The Celiac network on the top of this slide is a modulator of this particular dynamic between these networks. When our attention is oriented to something external and we are watching a sports game or presenting a lecture, the dorsal attention network is active. This task positive network couples with the central executive network, while the Celiac network blocks stimuli that are not important. For example, chatting in the background of the room, or maybe a bird singing outside of the room. And in contrast, when we are mind wandering, using our imagination or maybe resting, the default mode network is more active. In a normal person, the Celiac network can actually block, or at least partially block, external stimuli, so we can, for example, use our imagination or think about something that is inside us. And that's another network that we analyzed was the limbic system, which is involved in social emotional behavior and memory. We know that alterations in this network has been associated with antisocial behavior, social anxiety disorders also, borderline personality disorders, short-term memory loss, or also depression. So In our study, we included consecutive patients with intraaxial tumors from February to May 2021. And then we analyzed every network in three categories. Not affected if the network was not compromised by the tumor or perilesional edema. At risk if the network was displaced by the tumor or perilesional edema, or if it was showing close relationship with the tumor or maybe the surgical approach. And affected if the network showed damaged or missing tracts or pixelations by the tumor. All patients required 2 sequences, a T1 with contrast and a high resolution DTI with 2 millimeter slices. A very important part of our study, as I mentioned earlier, was that we wanted to explore something that could be implemented in our clinical setting. It's like we wanted to have a brain mapping lab at the base of the patient. And one of the things that we wanted to evaluate was the time it takes to process an MRI data set. So we first started with 81 different data sets from patients with brain tumors, pre and post-op. And from the moment we sent the MRI to the moment the process was done, the average processing time was 52 minutes, which we consider to be very good. So we can practically send the images before rounds, and by the time we are in the OR, the images are done. This is an example of how we use the platform for this. Oh, sorry. You can log in. This is a cloud-based platform. You look for the patient, and this is a timer, on real time, so you can actually see how long it takes. On the left side, you can see all the templates of the networks. On the right side, you can see actually the anatomical controls, and you can see while it's loading all the tracks and these small dots, those are the parcellations that we have discussed before. And we can see, for example, in this patient with a brain tumor, if we select the language system, it automatically retrieves all the information we need to analyze this network. We can see the tracks and the parcellations here, and then we can switch to a 3-dimensional view and plan our surgery. So this is very, very important because, for example, in this case, the language network is not only composed of the temporal and frontal contributions, but we also have the medial frontal, the SMA part, and the parietal and contributions to the network, which are also very, very important. And as we can see here, this is very, this is very similar to the modern publication that I actually explained how the language network is formed. So in this heat map, you can see that most affected networks were actually the central executive network in almost half of the patients, followed by the dorsal attention and the default mode networks. And while the least affected patients in our study, the least affected networks in our study were the visual, salience, and ventral attention networks. And why this is important, because we can see that the most affected networks are, interestingly, the ones that we do not consider most of the time. This is actually this is one of the most important results of our study. And also we found that patients with preoperative deficits showed a significantly higher number of altered networks before the surgery compared to patients without deficits. So we can expect a patient with neurologic deficits, they are going to have several networks affected. But patients that had no traditional neurologic deficits, they also have several networks affected. So, and these networks were mostly non-traditional eloquent areas. So as a conclusion, we know now that non-traditional eloquent areas are frequently affected in patients with brain tumors. What are the next steps? And next steps and future directions. We need to preserve cognitive functions in patients with brain tumors. We need to do this. This is something that has been around for a while. And I think that connectome-based surgery is going to be the future of neuro-oncology, but we need to know how to do it. And we are definitely pursuing that path. We need to understand how brain plasticity and reorganization works in patients with brain tumors. We are part of the Glioma Connection Project, which is a multi-institutional effort created to answer this question. And we need to integrate also neuropsychological data in our brain network analysis. And we think that artificial intelligence can help us with this task. We also need to try to find new ways of restoring brain functions. And all these concepts are fertile soil for neurointerventional rehabilitation, such as TMS. But one of the most interesting topics is actually theoretical neurosurgery. Can we simulate surgical resection and predict deficits? For example, if we take functional MRI and DTI and we can make graphs like this ball and chain picture, and these graphs allow us to perform complex math on them, such as centrality measures, average path length of hubs, etc. How do we figure out where are the biggest information centers of our hubs? What is the flow of information in the brain? We can use data science for that. We could use for example, like eigenvector centrality of PageRank centrality measures, which are very common in data science today, in the data science field today. Actually, PageRank was Google's original web page search algorithm. And we can weight each connection based on how many connections each node has. And by using these techniques, we can answer a very important question. Is eloquence related to hardness or not? And with all this information, we can basically take brain imaging, we can parcellate the brain, and then we can make graphs with measure the path lengths of all the paths in the brain. And then we can calculate a measure called global brain efficiency, which is a measure of how short or long that path length is. And in the context of a brain tumor, many path lengths are modified, altering the efficiency of the brain. And this efficiency is unique to each patient. So this is probably why we get different results when we, for example, are doing a frontal or temporal lobectomy. Some patients are fine, and some patients are not fine after the surgery. So in theory, we will be able to apply a mathematical model and perform every possible brain surgery, trying to predict which are the parts of the brain we can safely remove with minimum effects on brain functions. So thanks again for the invitation. It has been a great honor to be part of this meeting and sharing our research with you. This is my email, social media. So if you have some questions, please let me know. And thanks again, and have a great rest of the year.
Thank you, Alex, for this great talk. Another great presentation from the University of Miami. We have many questions over the panel. I invite Dr. Ashish to moderate the discussion.
Sure, thank you so much. There's a few questions to Dr. Ivan and Dr. Komatar. By Dr. Amoro, do you routinely use MR tractography preoperatively in tumors involving the eloquent cortex, and what's the utility of this?
So that's an excellent question. I would say that early on in my career, I used it all the time. And then I currently use it never. And the reason for that is that nothing is going to beat the gold standard, which is awake mapping. So early on, when you're not comfortable, you haven't done many of these, you want to get tractography. I think it's a great belt and suspenders just to know where to look. But I think once you've done enough eloquent region tumors, there's really no new information on the tractography. And at the end of the day, you're going to wake the patient up and you're going to do neuromonitoring and mapping. So at this point in my career, I do not use it. I rely completely on mapping. I think Dr. Ivan is moving that direction, but it's all based on experience.
Thank you.
And then another question from Dr. Rocovado. She is asking whether or not you recommend physical therapy to begin the process of recovery the next day after brain surgery.
It depends on if there's any deficits. If there's deficits, then yes, of course, physical therapy, and we get them to rehab right away. Something that we're working on, which is very difficult, and it's a part of the U.S. medical system, is if someone comes to you and they have a preoperative physical deficit, let's say that they're in a wheelchair, they can't walk because of their brain tumor, you know they're going to need rehab after surgery. You still have to have physical therapy see them and start the whole process, which at least here in this country, takes several days. Insurance clearance, bed availability. It would be great if you knew someone was going to need rehab after surgery, if you could get that process done beforehand. So something that we're working on and trying to streamline it.
Sorry, I think Dr. Scello had a question as well here. You're more than welcome to unmute and ask your question.
Anybody raising hands, you are unmuted. Please speak.
Okay, we can move on to the next question then, which was asking about Dr. Ghanem asked a question to all of us about if we maximize the extended resection for gliomas, it seems like it's better, but what are the technical advice you give to decrease morbidity from such a resection? And was there any difference in the outcomes for those patients?
So the answer is advice is nothing but experience. I would say you start conservative, and as you gain experience, you can get more aggressive. So we have done hundreds of lobectomies here to the point where we can do them through keyhole, craniotomies, small incisions. People go home post-op day one, and the anatomy is such that we know our landmarks because we've done hundreds of them. So to answer your question, I would say that you start conservative, and maybe if you have a right frontal glioma, maybe you don't do a full lobectomy. You take out the tumor, you take out maybe 1 or 2 centimeters more. And then as you get more comfortable, then you move towards a formal lobectomy. So we advocate, just like Dr. Shah said, for lobectomies in non-eloquent gliomas. Follow the anatomy, don't follow neuronavigation. And when you have enough experience, lobectomies are actually quicker, faster, and safer than just taking out the tumor.
Perfect. There are a few questions as well, but from Dr. Amir Hossein for Alexis. This would be more along the connectomics system, but where's the finite element modeling in this approach to analyze the brain shift? And then you pointed out to RTMS. Do you have the exact map for the frequency and regional RTMS? I don't know if Dr. Komatar wants to answer this question or Alexis.
Sounds like an Alexis question.
So basically, for the brain shift, we use preoperative MRI. So we generally you see the MRI before surgery, and we then analyze that data set in order to model the brain and try to map each network individually. And in regards to TMS, we are actually working on that. We don't have the data yet. Actually, there's no data. Yet, there are some centers that are working on that too, but we hopefully we will provide the data in the next years.
Perfect. That was good. I think all of us didn't know the acronyms there. See if any more questions that anybody else had. If you have any questions, just put it in the chat box here so we can answer them.
I think, Ashish, you received many questions as well. I know you answered over the panel, but attendees like to follow your answers. Would you say your questions? We have still 5 minutes to close the webinar.
Yeah, I think the main questions they were asking about, basically how to reduce morbidity and whether or not there was a difference in morbidity in our maximal safe resection group. And I think there was no difference in the operative morbidity and the complication rates, at least perioperatively and long-term in our patients. And the most important outcome when you looked at the differences was whether or not preoperative and postoperative KPS, whether there was a difference in the lesionectomy group versus the maximal safe resection group. And there really was no difference. I think Dr. Moro here asked the question, how soon do you start the Stoop protocol post-resection? And I think that varies depending on the patient and how well they're doing, but usually, anywhere from 10 to 14 days, we can start beginning Stoop protocol, usually 2 weeks or so. And if you have a stereotactic needle biopsy, we start it even sooner, or laser ablation. Correct me if I'm wrong, Dr. Komatar.
No, that's correct. Typically, anywhere from 2 to 4 weeks. The earlier, the better. But by the time they see the oncologist, get the planning MRI, it's typically about 3 weeks, I would say, is the average. And just like you said, the advantage of a laser is that you can start the treatment sooner, especially if it's a recurrent glioma. Obviously, you need to switch chemotherapy, start Avastin potentially. If you do a craniotomy, you obviously can't start Avastin for about 4 to 6 weeks. The nice thing about a needle biopsy laser ablation is you can start Avastin 1 week post-op, and we looked at our patients and there was no extra morbidity in terms of wound infection, wound breakdown, bleeding. So a recurrent glioma, if it's small and focal, laser is the best of all worlds. Make a diagnosis, cytoreduce, and get onto treatment ASAP.
And there's actually a few clinical trials out actually showing that expedited chemoradiation has a profound impact on survival for these patients, at least in 1 month or 2 months compared to, waiting, for the, tumor cells to kind of, come back after surgical resection. So, I think that the expediting adjuvant therapy is important, especially in the newly diagnosed patients.
I think now it's time. Any other comments or any other questions from the panel or from participants? I think now we came to the end of this webinar. I know that Ricardo has operations. Ashish has a flight and he has to go to airport right now. And so now I invite Professor Ricardo to say his closing remarks before I close the webinar.
Yeah, I just wanted to say thank you once again. This is a tremendous initiative that you've put together. It's amazing that you've done over 50 of these, which, as I said, is a tremendous resource for all neurosurgeons across the globe. It's a great collaboration. This was great for our entire group, showcasing our team here at the University of Miami. Look forward to future collaborations. Obviously, you guys know how to reach us. And again, kudos to all your hard work. This is truly a very impressive collaboration you formed.
Thank you very much, Professor Ricardo Comotor, who is the chairman of the Neuro-Oncology Division, Department of Neurosurgery, University of Miami. Actually, I would like to thank you on behalf of all African neurosurgeons, all Egyptian neurosurgeons, on behalf of the World Federation of Neurosurgical Societies, and all the 5 continents that you are encouraging everyone to promote neurosurgery in all the continents by this wonderful webinar we did together. And I would like to thank all our distinguished speakers who contributed to this activity. May I not forget to thank my organizing team, Dr. Hassan Ala and Ahmed Magdi, and thank all participants. Certificates will be sent to all participants within 1 week. Let me also announce about next webinar, webinar 56, next Friday, 17 December at usual time, 2 p.m. Egypt time, 12 p.m. GMT, which is going to be a collaboration with the Spine Committee of the World Federation of Neurosurgical Societies and Professor Salman Sharif. Thanks to all of you and hope to see you again in another occasion. Thank you very much.
Take care. Thank you.